during the present question answer that such that will be Moinak, Vinod, and Manojit. So that is the paper guided.
Good morning. Welcome back today. So we'll be having autism, genetics, epigenetics, and neuroimmune axis, which is very important, I think, basically, as we discussed yesterday. And I don't know whether it's true, I mean, whether it is true or not, but I always feel that epigenetics may be the game changer because you have those, modifiable things which is going to act on the epigenetics. And we have Moinak, who everybody knows has been working on, all this genetics and epigenetics, and he's going to speak on dissecting the double-edged sword of therapeutics, a link between common and rare disease. And he's in Rajiv Gandhi Institute of Genomics in Trivandrum. Moinak. Hmm? I always thought that you were placed in Bangalore for a very long time.
Very good morning to all of you. So I'll shift gears from different organisms. So today I'll be talking about the organism that makes we all of us there. That's humans there. So and my slides actually goes on in a way that to impress upon whenever we have to deal with a complex disease condition, what are things that we really need to worry about it. So I'll come to the autism at a later part. So before I'll try to talk about how do we assess a complex disease condition. Yeah. And my lab works on do a precise diagnosis for any given condition, do a precise medication for any given condition, and can I do disease forecasting. These are three domains that we try to work on there. And we try using genetics, epigenetics, pharmacogenetics, and pharmacoepigenetics. Pharmacogenetics is how your genome responds to the medication, and pharmacoepigenetics is how your epigenome responds to the drugs, and how the drugs modulate your epigenome there. So these are the two areas that we also work on there. And we also say that don't worry about the publication; anything will get published there, and that is what the domain is. So I'll try to show that why what all gets published there. We had not reached Mars, but surgery has been performed in Saturn there. So that clearly shows that anything that you think of publishing will get published there. But you have to do it very scientifically in the correct way there. So this is a very interesting publication which shows that the people have demonstrated that neurosurgery, how it can be performed in Saturn there. Hmm. So uh, taking this as a clue, what we did is when we started working on epigenetics of schizophrenia, and people say that schizophrenia is a very mature field, a lot of things have been already been published. So what we did is we tried to fish out all this information on published literature on epigenomics of schizophrenia, and I said that I don't trust any of this data there. The reason why I don't trust this data, because most of the epigenomic signatures that has been studied has been performed on either postmortem samples or on it or in the patients who are already into medications and all that. So I said that how do we justify that those methylation signatures that you're trying to see, they're not being influenced because of medication itself there. And then we went on to publish series of articles saying that yes, those methylation signatures that has been reported are actually all drug mediated signatures there. So they are not the signatures of pathogenesis there. So therefore, and these are all publications which has been published in Cell, Nature, and even PNAS and many other journals there. And it is 30 years work there. People have done it, and questioning the entire 30 years work on epigenetic schizophrenia is very challenging there. We also had a difficulty in publishing this particular article and questioning that these observations can be questionable there. And now people follow it. And just to impress upon that, yes, microRNAs, we again published that yes, these are the microRNAs which has been reported to be upregulated. Now we say that yes, those microRNAs can also be influenced because of the medications and all that. And then we also looked into the methylation patterns. So this was one particular paper where people have talked about methylation signatures by pooling the African Americans and the white Americans together there, and then they try to find out the methylation signatures there, and they all labeled as a American populations and all that. What we did is we tried to take up the data and then try to dissect out the African Americans and the white Americans there, and you can see that these are the signatures. This is the methylation signature which is reported to be hypermethylated in white Americans there, and the same site was observed to be hypomethylated in the black Americans there. So therefore, pooling this data, labeling that this is all Indian populations, this is all Indian data, this is all American data, one has to really take up with a pinch of salt, because we have to dissect out that yes, the population diversity really plays a role on having a different methylation signatures, different microRNA signatures, and many such issues and all that. So there are a series of such observations that you can see where there is a contrasting features between the white Americans and the black Americans. And then, and this is a PNS paper there. And then one also says most often we try to work out on identifying drugs for a given disease condition there. And if you literally go by the drugs that has been given for psychiatric treatments, so these are the various drugs that has been given for psychiatric ailments, and these are the targets that this particular drug binds to. But then, and this is routinely practiced. It means that you are aware that these are the genes which needs to be worried about whenever you undertake schizophrenia as a case, and therefore you try to treat those particular patients using those particular drugs and all that. But when you try to fish out, are these particular targets the real targets for and these antipsychotic drugs? There are series of such studies which says that serotonin receptors or dopamine receptors are not being associated with schizophrenia or drug response at all there. So which means that, and again, if you go for a whole genome data, this is a dopamine receptor, this is a serotonin receptors there. You don't see any of the studies except one or two which imply the role of serotonin receptors or which implies the role of dopamine receptors to be genetically associated with the disease status there. So it means that the dopamine receptors and serotonin receptors might not be the real disease causing regions for schizophrenia there. And then we published an article on Journal of Neuroinflammation where we say that it's inflammatory markers because schizophrenia is more of a pro-inflammatory phenotype there. And then when we are discussing with my clinician, he says that my patient responds to paracetamol much better than the antipsychotic drugs there. And if you try to understand this particular data further, you will see that haloperidol, clozapine, which actually are the most commonly administered drug for treatment of schizophrenia, actually are highly immunosuppressive in nature there. So that really puts a logic that yes, the drugs that you're taking are actually giving a response not because of its role in dopaminergic sites or serotonergic sites, but possibly might be playing a role through a completely by suppressing immunoinflammatory sites there. And as a result, you see that in the 2021, large number of drugs that has been developed is been developed only by looking at the genomic signatures there, not by giving a blanket hypothesis that these are the possibly mediators of the disease. And if you literally go further, these are the if you are more interested, you can go through these 4 books, which really talks about the bluff of the drug discovery process itself there. And what it doesn't talk, it also features in my presentation. What it doesn't talk is I give a complete talk on these 2 aspects, on how the drug discovery process is completely full of flaws, and post marketing, how the drug discovery can again be questionable. So these 2 areas which I normally, so this is a completely 30 minutes talk, which normally I can give you in a different occasion there. what are the real flaws of these processes. So this is on one aspect, that yes, whatever you see is you have to really try to, don't put an hypothesis, first try to work out with a completely no hypothesis driven work, and then try to let the data drive your observations and all. Then let me ask you, how many of you have these symptoms? These symptoms are very, very common there. And what happens if you have these symptoms? Possibly if you have an exam coming close by, definitely many of these symptoms will be very close to your heart there, right? And whenever you have these symptoms, the first thing that you will take is paracetamol there, right? And when you take paracetamol, paracetamol is we all consider it to be very safe drugs there. But you see that this paracetamol, prenatal exposure to paracetamol in pregnancy increase the risk of overall cerebral palsy and unilateral spastic cerebral palsy there. So it's not only these. So paracetamol is a very, very commonly abused drug, I will say. It can also result into ASDs, ADHDs, and even intellectual disabilities then. So paracetamol can really, and this is with the human studies and even with animal studies, people have shown, yes, this paracetamol can actually be very, very risky there. And another most abused, commonly abused drug is diclofenac. Diclofenac actually has an increased risk of cardiovascular risks there. And another very heavily abused drugs is set of NSAIDs. And you can see that most of the NSAIDs actually has a very high risk of cardiovascular risk there. I can keep on telling large number of drugs like that. And ranitidine, which is again acid reflux drugs, it can result in large number of cancers there. So therefore, once you think that you have come out with a drug, I don't really apply this particular role that I'm interested in drug discovery, because the moment someone comes out with such observations, I know that I have to close my shop and possibly go back to the jail there. Because if the patient really says that I have developed this cancer because of this particular medication, one has to really be very, very cautious there. So let us not be driven by the process of the pharma industry, because my own student, who is actually now the CEO of a pharma industry there. So he has to drive his industry only because whatever the owner says there. So therefore, don't think that the owners are very, very honest there. And another feature is that you are seeing these features. If you literally ask many of the clinicians, they will say these are all classical genetic features there. We have close to around 250 such individuals who have actually such malformed fetus or cleft lip, septal. These are very, very common there. These are all induced because of the anti-epileptic drugs the mother was taking when she was carrying the child there. And there are classical, but even now I work with 2 heart repositories in the country, and both of them are not aware that these heart malformations can be induced because of these particular drugs there. And not only that, these anti-epileptic drugs can result in large number of such malformations there. And on an average, 91% of the drugs that you routinely take have not been tested for teratogenic potential there. So even your administrators are also not aware that this is really true there. So this is one domain of things which I wanted to impress upon, that yes, whatever you do, you don't think of publishing as the major theme. Try to see that yes, whatever you're contributing is actually much more beneficial to the patients and all that. The second feature is that most often we talk about meta-analysis of given disease condition there. So I'll talk about how meta-analysis of a disease condition should be done there. So this is the features, the symptoms that I asked you initially are the symptoms of one of the very fatal condition, that is cerebral stroke there. And this is so fatal. A person, this happened in Trivandrum. A person, while giving a talk, he collapsed then and there, and he died instantly there. And most often, whenever you're trying to talk about the stroke, you talk stroke in isolation there. But stroke cannot be talked in isolation there. There are a lot of underlying comorbid condition that associate with the stroke and all. And when you try to find out the stroke and its comorbid conditions, you can see that this is what we did analysis of 194 countries all over the world, and we try to find out uh, uh, the rankings of various stroke and its comorbid conditions. You can see that it tends to vary. Don't worry about the small features, but try to worry about the color coding patterns, which distinguishes different color, different disease, different ranking patterns, and which clearly shows that yes, ranking of the different disease conditions, including stroke, actually varies across the world differently, which classically shows that ethnic parameters are very, very crucial to investigate any disease condition there. That's one thing. And when we group these comorbid conditions of stroke, these are the various comorbid conditions of stroke into metabolic conditions and hypertension and stroke. You can see that metabolic conditions are the major drivers for stroke in the Americans, Europeans, and Australians. But for India, East Asia, and Africa, it is the hypertension is the major driver for stroke there. This is again by investigating the data of 194 countries there. So this is when you talk completely from the public health point of view there. And I don't trust public health data very strongly. So I try to investigate this public health data completely from the genomic perspective there. And then what we did is we try to understand, we try to pick up all the GWAS data for all this comorbid conditions, and then try to see that can I distinguish this using all the GWAS hits for all the disease conditions, and can it distinguish the world population very precisely there. And you can see that yes, this is the Europeans, this is East Asians, this Africans, this South Asians, this is African, this American there. For stroke, ischemic heart disease, I can really distinguish. So you can see this is 326 loci, 866 loci, 378 loci for all these disease conditions, and all we try to do a structural analysis there. And where I can really say that yes, genetically we are stratified distinctly differently for all the disease conditions there. So therefore, a gene that has been identified for an American population may or may not be applicable to the Indian populations there. And if you want to go further, you can look into my eLife paper where we have further dissected about what are unique, what are common for all these features and all that. That is this paper there. And largely, mostly people try to focus either as a disease per se from the clinical perspectives, or even using model perspectives. Largely, most of the papers focus only on one disease at a time there. But disease doesn't happen as one disease at a time. There are a lot of comorbid conditions, whether we talk of autism, whether we talk of schizophrenia, whether we talk of stroke. So many of these conditions have a lot of underlying comorbid conditions there. And it's very, very crucial to understand, can I dissect these comorbid conditions using genomic signatures? Yes. This is one block, this another block. And if these two blocks come together, then I'll say that this disease and this disease might be co-segregating together there. But when they fall into two separate blocks, I'll say that these two diseases will not co-segregate there. So which means that if this block is present in one particular population, so this is very unique because in India, diabetes is not a risk factor for stroke, but in Finnish population, diabetes is a risk factor for stroke there. So therefore, in Finnish population, I'll presume that these two regions might be coming together. That's where the diabetes turns out to be a risk factor for stroke there. So anyway, I'll skip certain things, and as a result, whenever you are trying to work out with any complex disease conditions, whether it's autism, schizophrenia, or stroke, or any other conditions, we have to really very, very strongly focus on these four factors. One is to assess the phenotypic diversity that exists for the given disease conditions. We have to address the genetic diversity that exists for the disease conditions. We have to address about the epigenetic diversity that exists in the population, about the dietary factors and environmental factors that associates with it, and the comorbid conditions that associate with the given disease conditions. Unless we stratify these very precisely, we can't be able to focus on addressing the disease very precisely there. And if you are not still interested in this, I'll ask you one question: how many of you really like coffee there? Many of you may like coffee, right? And how many of you know that coffee drinking is good or bad for health? Right? So the people who love coffee, they will say coffee drinking is good for health, and people who hate coffee, they will say coffee drinking is not for health, not good for health. And this is what the evidences also indicate. These are the evidences indicate coffee drinking is bad for health. These are the evidences which indicate coffee drinking is good for health. I as a counselor, I'll be really thoroughly confused when I'm aware of this data there, right? So therefore, who decides coffee drinking is good or bad? It is your genomic signatures which decides the coffee drink is good or bad, because the caffeine has to be metabolized, and the metabolism is controlled by your set of genes, which says that yes, if you are a poor metabolizer, you should not be taking more than 1 or 2 cups of coffee per day there. But if you are a rapid metabolizer, you can take any number of coffee cups, nothing will happen to you there. The best example is that you have two persons taking the same biryani in one go. One person keeps on adding weight, the other person doesn't keep on adding the weight there. That's a very clear classical example of yes, your metabolic features are quite distinctly different from each other there. So you have to relate with whatever work that you do. You have to relate with your scenarios in and around you there. And the reason why coffee drinking, I took an example because coffee drinking is very, very crucial, which makes you hypertensive for autism there. So this you can actually really push to your patients also, that negative effects of caffeine for autistic children, and there are positive effects of caffeine for the autistic children and all that. But don't worry about it. You can really address it by looking into the genomic signatures of metabolism of caffeine, and based on that, you can really administer that whether coffee drinking is good for the autistic child or not there. So therefore, this is very, very crucial for investigating such issues. Now coming back to, so this was the background of what I was trying to talk about in terms of autism and all that. So autism, yes, there is a 317% increase of autism over the last 20 years. And when I say this, and I'm sure Dr. Shipali will also elaborate further on that, but at the same time, if you read this book, people will say that it's about autism, whether it's a reality or myth. The best example is that there is a hyper excitability from a lot of clinicians also to enroll the people for autism and all. I'll give you one example there with my own son. So he is normal there. He's not autistic there. But had he been in US or Japan or European countries, he would have been labeled as autistic child there. The reason is when he started speaking language in 6 months of age, but then we used to teach him Ma and Baba and all, and Khan, Mook, and Nak. And he used to go to my house owner's family, and they also used to teach him Mook, Nak, and Khan there. In Mook, Nak, and Khan in Malayalam and in Bengali is contrastingly different there. So Khan means this one in Bengali and Hindi, and Kand means this one in Malayalam there. So we used to teach him one thing, and he used to learn the same thing, but in a completely contrasting features and all that. And he stopped talking because he thought that either my parents his parents are foolish, or the house owner is foolish then. And he stopped speaking altogether, and he started watching all of us, and he used to direct us through language, sign language and all that. Had he been in the US or European countries, he would have definitely been labeled as an autistic child because he stopped speaking altogether then we put him into a play school. Then he realized that we asked the teachers to talk only in Malayalam there. That's when he realized that yes, this is a different language, and what we speak at home is different language there. And by the age of 3, he started speaking four different languages very precisely there. So therefore, I say that yes, autism to a large extent, this 317% that you see is actually really myth there. I'll skip this. Yes, there are a lot of features that associate with autism, and there are a lot of Jivas, whole genome studies that have been performed in autism and all that. How much of these Jivas data is really applicable? You can see this, the Jivas data for Chinese and Europeans. You can see chromosome 1 has been implicated, chromosome 12 has been implicated, but for many other ancestries, it tends to differ. For Japanese, it tends to differ. So Therefore, the one which has been applicable in one ethnicity may not be applicable across other ethnicities and all that. And this is what is very, very important to understand, that a gene that has been identified or fished up in a one particular population may not be applicable to your population. And similarly, when we did the Jiva studies in our studies, we also don't see that this particular gene has been picked up in any of the studies there. And when we had close to around 45 twins, and when we looked into the twins of this autistic children, we fished out there are plenty of such genes which we pick up in the autistic children from the twin studies of ours there. I'll skip. And another one of the major features for many of the neurodevelopmental conditions, whether it's autism or epileptic encephalopathies and all, the major feature is they are de novo in nature. What it means is that the parents don't have it, those mutations. You only have this particular mutations present only in the offsprings and all that, the probands there. So, and these are very classical features and all that. So therefore, one has to, whenever we have to do the studies on genomic studies, it is very, very crucial for autism or neurodevelopmental conditions. We have to really fish out the de novo mutations and all that. And why de novo mutations? Because the de novo mutations are the one which are actually a very strong phenotype there. So, and many of these de novo mutations, we have no idea what is functional implications and all that. So we have developed a software which can really fish out at a genome-wide scale what is regulatory functions and all that. And of course, don't worry about these data. When we really collect data and literature search, we see a lot of literature, and physiology, biochemistry, behavioral sciences, both are implicated there. And what is really features here is these are the therapist might be interested, and these are the features which I would be interested in. And if I literally impress on these, I'll say that melatonin, vitamin D supplementation, and folic acid are the major players which can be beneficial to treat the patients and all that. And if you literally look at the genomic signatures, which I don't know whether I have time to talk, and the genomic signatures of these actually really play a role in autism also there. And when we again do a literature search for various pathways, again immune response, circadian clock really picks up there. And then of course I'll skip. And there are again a lot of medication issues, and then various hypotheses also say that immunological factors play a role, and they all drive these neurotransmissions, and as a result, these are the 4 players which actually play a role in large number of symptoms and all that, which are autistic like symptoms and all that. And now, if you try to go for biochemical investigation of these parameters, what you get from the data, if you go do a literature search, you will see that tryptophan, dopamine, both have been reported contrastingly there. It has been reported to be increased as well as decreased there. From the clinical perspectives, to some extent, you can address this there, because this will really reflect on the symptomatic parameters and all that. But when you literally look into the biochemical parameters, it can be extremely confusing there. And that is when we try to investigate what is the feature symptoms in my patients. We found that we looked into the genomic signatures of the dopaminergic systems and the serotonergic systems, and we found that tyrosine hydroxylase, the mutation that has been associated, which results into decreased expression there. When it's associated with decreased expression, which means that you're not able to convert tyrosine into L-dopa very effectively there. So as a result, you'll be producing less amount of dopamine there. On the other side, the mutation that associates with the degradation of dopamine is indicative of increased expression of monoamine oxidase there, which indicates that you are actually overexpressing the monoamine oxidase. So on one side, you have a reduced amount of dopamine synthesis, and at the same time, you have increased amount of dopamine degradation there. So therefore, in my scenario, I will say that decreased amount of dopamine is more relevant to my patient scenarios then. And when I try to focus on those 4 parameters, you can see that many of these parameters are also have a second rhythmicity there. Yeah. again have a second rhythmicity there, which means that it differs from morning till evening and all that. And that is what the focus is. Are you controlled by yourself, or are you controlled by your genetics of circadian rhythm there? And again, when we looked into the genetics of circadian rhythm, we find that yes, in autistic children, the circadian rhythm genes are actually associated with autism in our patient scenarios there. And as a result, right. And as a result, we see that yes, these are the genes in the second rhythm genes which are actually genetically associated with autism children. And therefore, the sleep wake cycle, which is very disrupted, and one of the reason why I said that is very important, because most often you tend to see that this autism really happens in a high functioning parents and all that. So and therefore, which means that the parents are actually violating the second rhythm, and which really results into a lot of stress factors, which passes on into the fetus, and this due to which the fetus abnormalities really results into. I'll skip couple of slides just to impress upon one more question is that we all know second rhythm is controlled by light, and if this is true, there are plenty of Bengalis here. How many of these Bengalis actually are biologically morning type or evening type there? And if you literally see that classically all Bengalis, if Bengalis have been morning type, then then no questions asked there. But traditionally all Bengalis are evening type. So therefore the light doesn't regulate the second rhythm there, because in Bengal the light comes first. By the time it reaches Kerala, it's almost 6 o'clock. And but if you go to the streets of Kerala, by 4 o'clock, almost half of the Kerala is awake there. And this we did a survey of Bengalis and Malayalis, and we found that yes, there are a lot of a good number of people who are evening type. This is Kerala population. The 13% of the Kerala population is evening type, and good number of people are morning type. And this is the Bengali population. This is the last 26% of the Bengalis are actually evening type, and largely we are heterozygous in nature, and a very small number of people who are morning type there. And when you contradict your features, this can really result into a lot of executive function abnormalities there. Some are beneficial, some are disadvantages there. And if you further, so when he asked this question, I'll just take 1 minute to address this. I gave the same task to one of my students, and so and when I gave a questionnaire, she said that she's classically evening type, and I gave the same questionnaire to her parents. So the parents are classically morning type there. So then I said that then you are not the biological child of the same parents and all that. So, and I said whenever we do these surveys, these are extremely biased. We looked into the genomic signatures of the morningness and eveningness. We found that she was genetically morning person, and her parents were also genetically morning person there. And then she revealed a very interesting fact of her life. Said that up till 10th, you are all small kids. You listen to your parents religiously. Up till 10th, she was studying in the morning hours, and her results were very good there. 11th and 12th and subsequent colleges, her grades started falling in because she was not synchronizing her neuronal rhythm with the second rhythm there. If you synchronize it, one reading is more than enough there. If you violate it, you have to read at least 2 to 3 times and all. That extra effort that you're not giving it there, and that's where your effort fails in now. So with this, I just take 1 minute, which is very interesting, because how the socio-cultural parameters really drive evolution there. And you must have heard about Savant syndrome and this autistic children, which I label it as gain in brain function genes and loss in brain function genes and all that. And then we did a classically selection analysis at the genome-wide level, and we found there are 18 genes that are picked up which are positively selected, and the genes which are positively selected are these. And this particular domain is not present in all the ancient humans, primates, and all other things and all that. And this emerged only in last 5,000 years back. And if you try to investigate what happened in the 5,000 years back, and you will realize that 5,000 years back, the history of civilization really started there. And this history of civilizational cultures really resulted into establishment of this particular domain. And this domain is basically a more of a cognitive domain there. This domain got enhanced in the last 5,000 years, and due to which if you literally look into these genes, there are more associated with Savant syndrome there. So with this, I will stop. I can go on with.
Yeah, I know. Thank you,
Thank
Monarch.
you
You
very
are
much.
amazing.
Thank you.
And I think he was listening at my coffee intake. So, but the only thing is, I think, but the Americans have too much coffee, na, with Starbucks. So I think we can analyze that something because I think it's very interesting. And any one burning question, brief. It's very, very interesting. Actually, he can go on. It's very interesting of his work and all. And now he's, yeah, we can ask after tea, after the group photograph. Yeah. So now I will call on Vinod Skaria, the physician scientist we have in our country, a dear friend and a long-term collaborator who was in IGIB earlier, has been shifting gears, and now it is in Karkinos, and he's again in Bangalore now. More people going down south. He's talking about whole genome sequencing, when, why.
Very good morning to all of you. For the next 20 odd minutes, I think I'll highlight the what, when, and why of whole genome sequencing. Now, to give a brief background of what I'm going to talk about, I think I'll go to a bit back in history, and I'm sure all neurologists would sort of see themselves attached with it. And this is an invention that happened around 50 years ago by Godfrey Hounsfield, who was knighted later. And what he invented was this contraption, which for the first time in the history of humankind allowed clinicians to look inside the human body without having to open it up. Now, 50 years later, this invention, which today we call as a CT scanner, has pretty much revolutionized the way we practice clinical medicine, and more so in the area of neurology. Now, why did I bring this up is because it took 50 years, of course, for this technology to become something that is mainstay. And a city like Delhi would probably have around 100 CT scanners. What we have today is another technology which is sweeping the way we understand human body and human mechanisms, and that is our ability to not just peek into the human body, but peek into the human cells and every one of our 37 trillion odd cells, and that's essentially our ability to understand our genome sequence. Now, a genome sequence is approximately 3 billion alphabets, and every one of our cell has pretty much exact copy of the 3 billion alphabets. It took considerable amount of time to sequence the first genome, but of course, over time, that's increasingly becoming mainstay in clinical practice. Of course, I was fortunate to be in the team which sequenced the first genome in 2009, approximately 15 years ago, late back in December. And what we really put together is our technologies to now apply genomic sequencing into clinical practice. And I'll give you an example. This is way back in, I think, 2014 or 2015, where we worked very closely with Professor Shefali Gulati in trying to understand undiagnosed genetic conditions in the clinic. And this patient came to us with elevated lactate and pyruvate and microcephaly with small slit eye slits, and very characteristic presentation of a mitochondrial genetic disorder. And the Imagen score was also pretty high. And since we were the only lab at that point in time in India which were doing mitochondrial sequencing, we were quite excited to say that, okay, this is probably mitochondrial genetic disorder. Let's sequence the mitochondria and we should figure out what is in there. We did sequence the mitochondria, and what we really found is we didn't get any mutation. Now, that's not very uncommon in mitochondrial genetic diseases because a considerable amount of mitochondrial functional genes are actually encoded by the nuclear genome. And the next best approach that people would follow is essentially do a whole exome sequencing, which was becoming affordable at that point in time. And we did that and we got nothing. And typically, what would you do in such a case? Probably give up hope, and say that nothing can happen, or in Hindi, kuch nahi hoga. Now, what does this mean? Does it mean that the patient does not have the disease? Probably the answer is no, because it's consistent. The diagnosis is probably right. The scoring is probably right. And the next best thing to do is probably do a whole genome sequencing. And that is what we did in a whole genome sequencing. What we found is both the parents, we did a trio approach. Both the parents had a heterozygous genetic mutation, and the offspring had a homozygous looking genetic mutation. As you see here, we found one genetic mutation. This was a novel genetic mutation. Now, when you have a novel genetic mutation, you don't have evidence in literature to be able to assign it as a pathogenic genetic mutation. So what we typically go ahead and do it is to step into the lab and essentially create such genetic mutants in model systems. And in this particular case, what we did was to look at a zebrafish model system. We established that this genetic mutation indeed removed exons of two genes, CRCC8 and NDUF2, and this is just published much later. And we proved that this genetic deletion indeed what we caused the genetic disease. We went back to the pedigree and also used this for prenatal testing. As you see here, the whole genome sequence can essentially map the breakpoints. You have a heterozygous deletion in both the parents, the father and mother, and a compound heterozygous deletion, apparently looking like a homozygous deletion, but with overlapping breakpoints in the child. And of course, you could do prenatals also on whole genome sequencing to be able to ascertain whether the offspring is likely to have the disease. Now, of course, this family today has 3 normal children born out of sequencing their offsprings in prenatal settings, and today they are a very happy family. Now, this is not very uncommon, and there is very well documented evidence that whole genome sequencing today can be much better off in terms of diagnostic positivity. And this is a paper from Canada, which looked at multiple different kinds of genetic disorders. And what it suggests is that approximately around 40% of patients would get a diagnostic positivity with a whole genome sequencing. So what I'm trying to summarize in this early slides is that whole genome sequencing is all genetic test and more. Today, we use a variety of genetic tests, right from looking at karyotyping, array CGH, so on and so forth, to look at multiple kinds of resolution of genetic variants. You look at karyotyping fish for large chromosomal abnormalities. You use chromosomal microarray for anything from one to few kilobases of genetic abnormalities. Then you have many other kinds of genetic variations, including repeat expansions. You have deletions, and you have, of course, single nucleotide variations, which you can do either by Sankar sequencing or a panel sequencing on NGS. And each of these tests are typically done in a cascade approach in clinical settings, and considerable amount of time, energy, and effort is actually lost in such cascade testing approaches. What I'm trying to say is that today we have an ability to sequence whole genomes much faster than any one of these tests, and becoming very self-encompassing that you don't need to do multiple tests anymore. You can actually do one single test and be done with it. And we have over and over shown this in multiple different cohorts. This is for a different cohort of cardiac channelopathies. We have looked at exome sequencing and looked at all exome negative tests. And what we showed is that using whole genome sequencing, we can consistently increase the diagnostic positivity, ending from 15% to around 25% is across the spectrum of genetic disorders that we have looked at. And that consistently means that whole genome sequencing at any point of time is a much better genetic test than any one of these genetic tests. The second thing that we can really glean out of whole genome sequences is to understand what is really prevalent in the population. Now, when we talk about patients and patient samples, they typically come with one genetic event, while the rest of the genome essentially is representative of the population. Now, that can be really gleaned to understand what is really prevalent in the population. And this is very important because policy matters are dependent upon what is really prevalent. And to understand what is really prevalent, one of the ways and approaches to do that is to go to a clinic and sit with a clinician and tell what is really prevalent in the clinic. And of course, if you meet somebody like Professor Shefali Gulati, who is a pediatric neurologist, who will see pediatric neurological conditions. But if you go back to a pediatric cardiologist, that pediatric cardiologist will tell about pediatric cardiological disorders. And therefore, there is never a consensus of what is really prevalent in the population. And one way to look at prevalence is to essentially be able to sequence apparently normal individuals like you and me, and ask the very simple questions: what do you carry, or what are the genetic variations that you carry? And look at that carrier frequency across populations to be able to now go back and predict what is likely to come in the clinics. And if there's a gap between these numbers, what clinicians see and what is prevalent in the population, that means that there is a diagnostic gap. That means the patients are not being diagnosed appropriately, or there's an awareness gap. And both these gaps, fortunately, today can be changed with technology. Now, let's take the case of intellectual disability. And of course, intellectual disability is a very common pediatric neurogenetic set of abnormalities. It could be coming from multiple kinds of genetic disorders with multiple kinds of inheritance, whether it's dominant, recessive, or X-linked. There could be monogenic causes. They could also be overlapping with inborn errors of metabolism. And of course, if you look at the spectrum of genetic variations, you would see that a significant large majority of them would be unknown because we don't really know the genetic basis of it, including, for example, autism spectrum disorders. You have chromosomal abnormalities, which considerably around 15% of individuals. And therefore, you would understand that each of these patients with intellectual disability, therefore, goes through multiple kinds of tests on a cascade approach. Now, if you really knew what were prevalent in the population, you could actually go back and understand and make this testing much more streamlined. And that's what we did very early on, to look at one subclass of genetic disorders causing intellectual disability, but nevertheless treatable. Now, today this number is improving. At that point in time, a few years ago, it was around 80 disorders with around 100 odd genes involved. We looked at the genetic frequencies of pathogenic and likely pathogenic mutations across the Indian population from around 1,000 odd Indian genomes, apparently normal individuals. And what we show is that the carrier frequency of some of these genetic variations are extremely prevalent in the population. The best example I would suggest is ATP7B. The carrier frequency of ATP7B pathogenic mutations in the Indian population is approximately around 1%. That would roughly mean that 1 in around 40,000 children born in this country would have a very treatable genetic condition. And this treatable genetic condition can be treated not with a 70 lakh rupees drug, with a very cheap and effective drug, which costs approximately 3,000 rupees, provided you can diagnose them very early on. And we have many more genetic disorders, including phenylketonuria, biotinase deficiency, which are all very prevalent in the population. And therefore, this population scale probabilities or population scale allele frequencies can inform what are the genetic diseases that we should probably screen very early on with a high level of suspicion. And of course, we could do whole genomes, and whole genomes are still not affordable in a country like India. But of course, people would use a lot of whole exome sequences because that is very well affordable and in the affordability limit of many individuals today, and increasingly becoming affordable over the last few years. But then when you do a whole exome sequencing and you want to look at a chromosomal abnormality, typically what you do is a cascade screening approach where you club it with a chromosomal microarray. And typically that takes enormous amount of time, effort, and of course, with much lesser diagnostic positivity, because there are two different kinds of assays looking at two different kinds of things. So one of the things that we thought of doing is to essentially combine both of it. And the idea of doing both of it is that you can do the best of whole exome sequencing, where you can get exonic coverage much very efficiently. You can get to a broader coverage across the genome using whole genome sequencing. But instead of a 30x whole genome sequencing, here we do something like a 5x whole genome sequencing, which can capture the copy number variations very effectively. And this is an approach which is known as a blended genome and an exome. And the essential idea is that you capture the best of both. You can look at the copy number variations very effectively, and you can also look at the exonic coverage much more effectively, sort of replacing out the MLPA chromosomal microarray and mitochondrial genetic diagnostic test, which are add-ons to whole exome sequencing, while essentially making it very cheap and affordable, pretty much double the cost of a whole exome sequence. This is one of such cases that we sort of worked upon. As you see here, of course, the exome is suggestive of something that is really abnormal, but not really confirmatory, because you could have exonic drop-offs because the probes did not probably work. This is the patient and the parent. Since it involves a very important gene, we were really interested in looking back at it, and it sort of coincided with the phenotype of the individual. So we did a blended exome genome, and as you see here, you can absolutely accurately map the breakpoints at base pair resolution. And this, I think, is going to be a revolutionary technology where we can sort of do away with multiple rounds of genetic testing or cascade genetic testing and replacing it with a very cheap, affordable single test, putting in the best of both genomes and exomes. Now, before I close my talk in the last session, what I'm trying to also highlight is that the cost of genomic sequencing is dwindling very rapidly. And I'm not sure you'd appreciate this fact that this is on the log order, not on a linear order. And what you see here essentially is that the cost of genomic sequencing is becoming half every approximately 150 to 180 odd days. And the dotted line is essentially the Moore's law for semiconductor industry. And you would imagine that for the first time in the history, biological data generation is surpassing the computational power of the Moore's law. So that also would mean that we are at the verge of a very interesting time where a technology like whole genome sequencing, which we increasingly use in discovery, is shifting into the application domain. And I think in a decade's time, this is a technology that we think will become routinely used in clinical settings, just because it will become so affordable, probably a few tens of dollars, and that would necessarily mean that you and me can also get the whole genome sequencing done. And that would also mean that we would have a paradigm shift in the way we use genomics in clinical practice. Today, we use genomics in clinical practice on the assumption that a patient comes to you, a clinician sees a patient in the clinic, the patient finds a clinician rather, and the clinician observes the individual, takes a history, and of course, does a set of labs. And genetic testing is today used to confirm the genetic diagnosis. But you need to keep in mind that the patient has already developed the condition, right? And there is very little that can be done at that point in time to be able to treat that patient. But now assume that you could do your genomes even before that, right? Apparently, healthy individuals like you and me could use their genomes. Then we could use the genomic evidence, which is available and increasing over time, to be able to ascertain what is your risk of developing a condition. And if you could know that, then you could approach the clinician and be able to treat them very effectively. And I think if this is something that is off the limit, that is not really true. And the essential idea is that today what we use is in genomics is to diagnose, to prognosticate, and to treat, and of course to monitor some condition, like for example in oncology. And that's largely after you have developed the symptoms and signs. So an individual has already been deceased. Now, how can we really move this needle to the preclinical phase, where you can essentially come back and look at the germline risk and use it as a screening approach? Now, we did this very interesting hypothesis and analysis on the Indigen program, which is 1,000 odd whole genomes from across the country. And what we found was even more remarkable, that approximately 5% of individuals in the population, or 1 in 20 of individuals in the population, do have a germline risk for a high probability genetic condition. And this would include approximately 2% of individuals for hereditary cancer risk. This includes BRCA1, BRCA2, PALB2 check, and the colorectal cancer gene, 6 of them. Put together, 2% of individuals would develop a high-risk cancer, either breast, ovarian, prostate for BRCA1, BRCA2, or colorectal cancer. And approximately another 2% of individuals would develop a cardiovascular disorder with high probability. This includes familial hypercholesterolemia, cardiac channelopathies, and cardiomyopathy. And put together, the top 10 prevalent genetic disorders would give a number of approximately 1 in 20. And that would mean that's an enormous opportunity that is being lost by individuals probably not doing their whole genomes, even when they're apparently normal. But of course, having said that, one of the other approaches to do this is to essentially put the needle early in newborn. And the idea is to essentially identify very prevalent, penetrant, diagnosable genetic conditions which are treatable. And a subset of treatable genetic conditions are improving quite very rapidly. And it's not just about the population of India. There are many other populations who are increasingly doing rapid or ultra rapid genomic based newborn screening. And the idea of this is very simple. You can look at a genetic set of disorders which are treatable in that particular population, which has a very high evidence of actionability. And if they're highly penetrant and if they're very prevalent, you need to screen them. And the best screening programs across the world, including, for example, the US, looked at universal screening for around 37 odd genetic conditions. But of course, the numbers of genetic disorders covered in individual states are very different. But genomic sequencing today offers a much broader coverage, not much beyond 37 genetic disorders. Today, there are around 150 odd genetic disorders which are treatable in the best of the best centers. And to put the prevalence, this would approximately mean that around 1 in 182 individuals born would have a treatable genetic condition. And in many ways, this is an underestimate. And of course, there would be population-wise differences between the genetic disorders, as I sort of alluded to earlier. And given this background, what we think is that increasingly we would, and increasingly as genomic sequencing would become much more affordable, the newborn screening programs would all get converted into a whole genome newborn screening program. And Of course, there are now clinical trials on it to sort of assess the positivity of such programs. And this is not for all newborns. This is for sick kids in the newborn ICUs. And what the study shows, which is a randomized controlled trial, it shows is that either you use a WGS or a WES is not really going to change the positivity. This is consistently around 19 to 20%. But of course, if you use a rapid WGS for extremely sick newborns in the clinic, you could have a positivity of approximately around 46%. A significant number of them could be very treatable genetic disorders. In other words, today you can have a genetic test which can deliver at around 4.6 days on an average, or around 11 days on an average, in a rapid mode, to be able to ascertain the genetic condition of sick children in the newborn period. But even if you are not sick and if you are apparently normal, you can still use this data all throughout your lifetime, because the germline genome is constant from the day you're born to the day you're dead. But the applications or the questions that you would want to ask at different points in time in your life are going to be extremely very different. In early newborn period, you would want to look at treatable genetic disorders. In childhood, of course, you would want to look at much more number of genetic disorders which are increasingly becoming treatable. In early adulthood, you would want to look at genetic disorders which have adult onset, which are typically missed out in clinical settings. This includes MODY, which includes cardiac channelopathies and cardiomyopathy, which are also quite very frequent in the population. And of course, you're in the middle age, you would want to use this information for carrier screening and reproductive decision support, especially if you're an individual marrying within the same community, what you call as an endogamous marriage practice, which is very common in the Indian population. And the middle age, of course, you would want to look for cardiac and neurodegenerative disorders, many of them which are increasingly becoming treatable and have targeted therapies. And of course, in the older age, you would want to look at malignancies and neurodegeneration, including Parkinson's disease, which have now targeted therapies available. And all throughout, of course, you would want to look at pharmacogenomics. That's the approach where you use genetic information to modulate the dosage of the drug or avoid drugs which would have adverse drug reactions. I think in summary, the take homes are that genomic sequencing is becoming very affordable for routine clinical implementation, and probably in a decade's time, I would not have to give this talk, and probably half of you would already have your genomes done. Genome sequencing can enable a disease diagnosis in an undiagnosed disease setting, especially at an individual level, and aggregated data for individuals across the population would provide very useful insights for public health implementation. Genetic diseases are extremely prevalent in the population, and undiagnosed, approximately 1 in 10 individuals in the adult population do have a genetic condition. And therefore, genomic sequencing is not just for patients, it's also for apparently normal individuals. And one thing you need to keep in mind is that genomic evidence is for a lifetime, and genome sequence is also therefore for a lifetime. The evidence is changing very rapidly, and therefore the utility also is. Thank you very much.
Thank you, Vinod. You're amazing as always. Any comments, questions?
Thank you. Very nice. We do a lot of transcriptomic studies in mice and with mouse brain samples. And one thing that was sort of obvious, but I never estimated the impact to be so big, is that the annotations that we have are completely lacking detail and are incomplete, right? So that means there are loads of alternative transcription start sites that are not annotated. There are splice variants that are not annotated. And I wonder how important is it to have a parallel effort to genome sequencing to be actually able to interpret the information that you're gathering?
Yeah, absolutely, absolutely very relevant question. So as you would have imagined that in exome sequencing typically look at protein coding exons of genes, right? What whole genome sequencing essentially is giving you as a much broader overview. And today we know there are a significant large number of known coding genes in the whole genome. This includes smaller genes like microRNAs and much larger genes like long non-coding RNA. And there are also situations where the long non-coding RNA and non-coding transcripts are actually alternate transcript isoforms of a protein coding gene. Now, what we increasingly are discovering using whole genome sequencing is our ability to look at non-coding RNA genes which cause diseases, which was never known before, but we are increasingly discovering them because there are deletions which overlap many of these genes, and we are discovering these new genes and new disorders. The alternate part of it is, of course, the transcriptome part, because the alternate transcript isoforms give you a very useful clue on a subset of genetic disorders which are missed out earlier, which are including the regulatory gene mutations and the intronic mutations, which were not previously amenable to sequencing and analysis, clubbed with the transcriptome sequencing allows you to ascertain the functionality much better and much easier. So in my opinion, it is still not a genetic test to be done on patients, but it's a functional assay that can correlate with the genetic mutation that you discover.
Yeah, I just think that sort of something like an expanded ENCODE project would basically be needed on different tissues, right? Because
That's
that's the other realization that this is extremely cell type specific, what's happening there. Yeah.
But apart from that, in the space of oncology, transcriptome sequencing is something that is now increasingly being routinely used because there are gene fusion events that you would want to look for.
I'm not as much of an expert on the technology for transcriptomics. I do agree, with what Peter was saying that, to the extent that we do transcriptomics, the, functional interpretation of the data is always a challenge. But yeah, it's not totally my area, so I'm not.
Hi, sir. Nice talk. The question is that whole genome sequencing. Not on? What? Whole genome sequencing does not really account for the epigenetic changes and modifications that would occur throughout life of an individual, right? So even if the child is getting an early whole genome sequence, and we know that the child does not have any problems in the sequence and all, epigenetic modifications might cause other diseases, right? So how would you in future maybe want to deal with this question?
So you have a very pertinent point that epigenetic modification and epigenetic changes could indeed cause genetic disorders. And there are very good examples of epigenetic disorders also. And the point I'm trying to make is that whole genome sequencing is not to ignore those facts. In fact, whole genome sequencing technology is improving so that you can actually do the 5th and 6th base pair calling on a whole genome sequencing with newer technology. Like, for example, the PacBio or the nanopore, you can actually do 6 base calling on a whole genome sequencing to start. Plus, sequencing is improving. Of course, we are going to identify many of the new events which were not uncovered before.
So, do you want to in future looking at to combine the genomics mutation information along with the proteomics data and combine for this kind of personalized or approach for drugs, right?
Yeah, I would not buy into the idea that you do a genome and then also do a proteome, because of the fact that even when you talk about epigenetic changes and epigenetic mutations, the basic tenet of that change is essentially encoded in your gene.
True.
Right? When you talk about epigenetic disease, the basic mutation that causes that epigenetic change is also in your gene. So it is only that genomic sequencing analysis is going to be much more powerful as we factor in those understanding that we today do not. Until we do quite some number of more genomes across environmental settings is when you understand what are the genetic mutations which cause that epigenetic. Now, the proteome and the transcriptome are the outcomes of these changes. So to me, the proteome and the transcriptome are functional assays, largely to be used in the research setting, with exceptions, of course, when you can use it for early screening approaches when you have a direct correlate. But apart from that, I think a much more cheaper approach would be to use a whole genome.
Thank you.
At scale.
Thank you. Thank you so much. Thank you. It was really amazing. Now I will request Monosi Devnath, very senior and experience from the Clinical Advocacy Center, Activation and People Programming of the Neurodevelopmental Disorders. He has the audio for.
yeah, correct. Yeah. Uh, a very good morning, the esteemed audience. At the outset, I would like to take this opportunity to thank the organizer for inviting me to give a talk in this event. The topic of my today's discussion is prenatal adversities, maternal immune activation, and fetal programming of neurodevelopmental disorders. I see many students in this audience, so I would like to spend a few minutes on the background and hypothesis of this topic. Then I'll move to my research findings. Let me start on a lighter note. We all know that we have 5 sense organs. These are optic, somatosensory, auditory, gustatory, and olfactory, and a highly debated 6th sense organ. Some people say proprioception, the sense of body position and movement, is the 6th sense organ, while others say vagus nerve is the 6th sense organ. Let this debate continue on 6th sense organ. Meanwhile, a new sense organ has emerged in human biology. What is that? So we all live in an ocean of microorganisms. Some of the microorganisms, they antagonistically invade us. Some of the microorganisms, they live inside us. And some of the microorganisms, they just surround us. So do you people believe that there is no sense organ within our body to recognize the activities of this microorganism and send signal to the brain? Yes, it is indeed there. It is nothing but our immune system. Now, this notion can further be substantiated by drawing a parallel between sensory nervous system and the sensory immune system. So yeah, if you draw parallel between sensory nervous system and the sensory immune system, for the sensory nervous system, you need sensory input, and this is followed by capturing of the signal and integration of the signal. Of course, you have signal in independent parameter that also kind of modulate the sensory function of the nervous system. So similarly, if you look at the immune system, so you have immune signals. These are no external signals or dangerous signals from the body, and the signals have to be captured and integrated through signal transduction. And of course, these are also modulated by different factors like gut microbiota, metabolic status, age, and gender. Now, this understanding, along with the recent conceptualization that immune system is completely hardwired with our brain, and there is active crosstalk between the immune system and the nervous system. Now, this conceptualization has led to the birth of a new and very hot, exciting field, that is neuroimmunology. Okay, so why immune system is so special for the brain and behavior? Immune system is special because it has yin and yang property. Now, yin and yang is old Chinese concept, and it can be exemplified by cosmic duality of our universe. That means you have two sets of opposing and complementary forces that governs the universe. So similarly, immune system also has this yin and yang principle. So you have activators and effectors immune cells. At the same time, you have regulators and controllers. You have pro-inflammatory cytokines, you have inhibitory cytokines, you have activating receptors. At the same time, you have inhibitory receptors. Now, these attributes, yin and yang attributes of the immune system, allows the immune system to perform many regulatory functions. So immune system basically has both immune function as well as non-immune function. The non-immune functions or neurological functions of the immune system is very important because these are involved in the crucial phases of neurodevelopment in early life. So that's why immune system is very, very important for brain and behavior. Now, coming to the historical roundup, for several decades, in fact centuries, immune system was considered, the brain was considered as immunologically pristine site. Why? Because we do not have, I mean, the people used to believe that there is a lack of classical lymphatic system. For effective immune system, you need blood vascular system as well as lymphatic system. So people thought there is a lack of classical lymphatic vessels, absence of professional antigen presenting cells, then low expression of major histocompatibly complex class 1 and class 2 molecules, and of course there is blood-brain barrier, and finally the brain is completely isolated from the peripheral immune systems. Now this proposition was based on certain experiment. People early in 1920, 1925, they performed a series of experiments. They found that when tumor cells were implanted into the periphery of the body, so it was rejected. But when tumor cells were implanted into the brain, there was very feeble immune response. And this was again supported by additional experiments where people transplanted foreign homologous tissues into the brain. So brain did not induce any immune response against the transplanted antigens. Now, this misconception was proved wrong by the seminal works of Peter Medawar. Of course, he got Nobel Prize for his transplantation experiments. So what he did? So he first transplanted skin graft in the periphery. There was first rejection. Then he transplanted the skin graft into the brain. There was very slow rejection. Then he transplanted the skin graft into the periphery and then into the brain. Then there was a first rejection. So this is the breakthrough which proved that brain does have immune system, and this was further supported by, I mean, the study almost after 40 years. So where after injury, macrophages and T cells were found to protect neurons from damage and also played important role in the recovery. Now, the final breakthrough came in 2015 because people believe that brain doesn't have classical lymphatic system. So in this, so in this study, for the first time, a classical functional lymphatic vessel was identified in the brain. So why it was not identified or discovered earlier? Because of its anatomical seclusion. So lymphatic vessel is found within the meninges, especially in the dural sinuses. Because of this anatomical seclusion, it was not, people were not able to identify or find classical lymphatic system. Now this classical lymphatic, why it is classical lymphatic system? Because it bears the expression of most of the molecules which are found in the peripheral system. Now with this discovery, then the next question was that how immune cells from the periphery they transmigrate to the brain. So because brain has multiple layers of protection, like blood-brain barrier and other barriers. So it was found that choroid plexus, I think we all know that this is a center for production of CSF. So choroid plexus has got fenestrated capillaries. So immune cells from the periphery, they can enter into the brain through these choroid plexus, fenestrated capillaries of the choroid plexus. And along with CSF, it can actually take immune surveillance across the brain parenchyma, and it can go out through venous sinuses. Otherwise, the capillaries which supply blood to the parenchyma, they create perivascular space, and then this is further divided into post capillary venules. Immune cells can enter into the brain parenchyma through this post capillary venules. Now the question is that how peripheral, because Medawar experiments demonstrated that you need training of the peripheral immune cells if they want to transmigrate to the brain. So the immune cells which have the potential, which can acquire the potential to transmigrate to the brain, they can only enter into the brain. So this potential is basically nothing but to response to the adhesion molecules and chemokines. Now, what are the sites of entry of immune cells into the brain? So these are like brain capillaries along the blood-brain barrier. Then you have fenestrated capillaries in the choroid plexus, meningeal vessels in the brain parenchyma, and of course post capillary venules. So now we understand that we have a functional lymphatic system in the brain. Then we understand how peripheral immune cells transmigrate into the brain. Now 3 more discoveries made this subject a unique one. So what are these? So subsequently people realized that choroid plexus is the gateway for the transmigration of the immune cells into the brain. Now we know how immune cells from the capillaries, they transmigrate through the pyometer, through the endothelium, and then ultimately through the epithelium, and then into the ventricular space. So this activity is very much well known now. Because of this, we call immune choroid plexus at the immune hotbed. Subsequently, now another discovery was the meninges. So meninges, no, now we call it as immunological wonderland, because people used to believe that we have to depend on peripheral blood cells. No, now no longer we have to depend on peripheral blood cells because brain has its own protector. So we can obtain immune cells from the bone marrow of the skull and vertebra. Subsequently, after demonstrating that brain has immune hotbed and immunological wonderland, then another discovery was lymphatic system, because the garbage and the waste from the brain has to be removed. So now we know that the functional lymphatic system in the brain. So with this background, I move to my current research areas. So that is immunopsychiatry. So why there is so much of hype on immunopsychiatry? If we look at the evolution of the scientific publication, you see, so there are close to 1500 or 15,000 publications when I use the keyword immune and psychiatry. There are close to 3,600 publications when I use the key term immune and schizophrenia. And with respect to immunity and autism spectrum disorders, there are more than 2,000 publications. Okay. So what are the basic hypotheses why immune system is important for neurodevelopmental disorders? Because inflammation can disrupt developmental programming of these neurodevelopmental disorders. And there is potential interaction between all early life adverse risk factors with the immune system. The early life adverse risk factors can potentially modulate the function of the immune system. Now, inflammation actually has appeared as a common subset for many comorbid conditions. And then subsequently, inflammation can induce neuroprogressive changes. And finally, inflammation can mediate transgenerational epigenetic inheritance, and also it can shape the immune phenotypes in the subsequent generation. Now, with this, in 2015, we proposed this hypothesis, that is fetal programming of schizophrenia. Schizophrenia is a neurodevelopmental thought disorder. So what is this? So we proposed that a host of endogenous risk factors along with a host of exogenous risk factors, they basically modulate the function of various physiological pathways. This can be immune pathway, this can be redox pathway, this can be tryptophan catabolite pathway. By modulating this pathway during neurodevelopment, they can actually enhance the risk of neurodevelopmental disorders in the offspring. So this basically acts on a two-hit model. So what is two-hit model? The first hit, basically it can be environmental or it can be genetic. The first hit happens during prenatal development, and this hit leads to neuropathological priming, specifically priming of the microglia. And after birth, during adolescence, exposure to the second hit in the form of stress, in the form of childhood trauma or infection, this can lead to unmasking of the first hit and unmasking of the neuropathological changes, and this can lead to manifestations of neurodevelopmental disorders like schizophrenia. Now, after publishing this, we did a mega-analysis and we realized that it is not basically two hit. For the manifestation of neurodevelopmental disorders, especially schizophrenia and other disorders, you need multiple hits across the lifespan. So these multiple hits can include both biology and as well as environmental factors, and this can lead to the manifestation of schizophrenia-like behavior. Now we wanted to validate our hypothesis. So one of the most predominant prenatal risk factor is prenatal infection. Multiple epidemiological studies have shown association between prenatal infection and the higher risk of neurodevelopmental disorders in the offspring. So these are some of the prenatal infection. It can be protozoan, it can be viral, it can be bacterial. This prenatal infection essentially leads to maternal immune activation, and then it has severe consequences across the lifespan. Immediately, it can lead to severe brain malformation. In the infants, it can lead to postnatal cerebral palsy, and in the child, it can lead to autism. And during puberty and adolescence, it can lead to schizophrenia, depression, and finally, in the adult population, it can lead to Alzheimer's disease and Parkinson disease. Now, the question is that something happening during prenatal life, how it can have such a long-lasting impact on the brain and behavior of the offspring. So we need to identify the missing link. What is the mechanism for biological embedding of the prenatal adversities? Okay, so coming to this, we hypothesize that it is basically through the programming of immunoinflammatory, oxidative, and nitroxidative stress pathway. So in utero infection or prenatal infection can leads to developmental neuroinflammation by activating the IONS pathway and priming of the microglia. This during adolescent and subsequent exposure to the postnatal stressors, it can lead to progressive brain pathology. And we wanted to validate this hypothesis. For this, we developed animal model of schizophrenia. Okay, so what we did, basically, we took Sprague-Dawley rats, pregnant rats, and at GD12, we injected bacterial analogs, that is LPS. We injected viral analogs, that is poly-IC. And after 24 hours, we assessed maternal immune activation by quantifying the levels of pro-inflammatory cytokines. And then the remaining sets of the rats, they were allowed to complete the pregnancy. And during peri-adolescent, that is postnatal day 39 to 44, and adult period, that is 60 to 70, we examined the behavior of the pups, and we also examined the pattern of expression of genes belonging to different pathways: apoptotic pathway, inflammatory pathway, and oxidative stress pathway. So the findings are very interesting. So in the maternal immune activation due to infection led to peripheral inflammation because the levels of the inflammatory cytokines were very high in the offspring, and the levels of gene expression of inflammatory markers were also high in the hippocampus of the brain of the offspring, and there was a positive correlation between peripheral inflammation and neuroinflammation. Besides this, we also measured the levels of oxidative stress marker. So we found that the levels of malonaldehyde was very high in the offspring brain, and the level of total antioxidant was less in the offspring's brain. Besides this, we also quantified the level of gene expression of various apoptotic marker and neuroprotective marker. The expressions of apoptotic marker like BAX, caspase-3 and caspase-9 were significantly high in the brain of the offspring, whereas the neuroprotective marker like BDNF and BCL2 were significantly downregulated in the offspring. So this suggests that prenatal infection leads to maternal immune activation, and this leads to behavioral abnormality. Like in the offspring, we found abnormality in social behavior. There was a deficiency in the social behavior. Yes. Hippocampus for the neuroinflammation. Yes. 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 And there was a deficit in the social behavior. There was alteration, impairment of the PPI, sensory motor gating, and there was abnormality in the anxiety-like behavior. So this proves that prenatal adversity can lead to fetal programming, and then subsequently it can enhance the risk of neurodevelopmental disorders. So this is the finding from preclinical models. Next, I'm moving. Okay, so there were some more additional experiments. So basically, toll-like receptor is the first line of defense, and then inflammasome is the initiator of the inflammatory cascades. So we wanted to examine the impact of prenatal infection on toll-like receptor pathway and inflammasome pathway in the brain of the offspring. We found that the expression of toll-like 3 and toll-like 4 receptor, as well as the expression of inflammasome components like NLRP3, caspase-1, IL-1 beta, IL-18, all were significantly upregulated in the hippocampus of the brain. And then subsequently, we correlated the expression of these inflammatory markers with the apoptotic as well as neuroprotective markers. With the apoptotic markers, they showed positive correlation, whereas with inflammatory neuroprotective marker, there was negative correlation. So these findings suggest that prenatal maternal immune activation elicited by prenatal infection can induce neuroprogressive changes in the brain. Now coming to a very interesting study. So this is Bangalore Child Health Development Study. This is a birth cause study, and this study is going on for the last 10 years. And this is funded by MRC UK. Okay, so in this study, we have collected data from the pregnant woman, first trimester, second trimester, and third trimester. We have collected biological samples, and we studied the prenatal adversities. So this is basically prenatal psychological adversities in the pregnant woman. And then we followed the cohort. I mean, we are following till 9 years. Now we are at 5 to 7 years, and we'll follow it till 7 to 9 years. So the main objective of this study is to understand the impact of psychological stress during second trimester on prenatal maternal immune activation and subsequently on the internalizing and externalizing behavior in the offspring in Bangalore urban settings. So what we are going to do basically here, so we collected maternal blood samples and then we assessed the depression, anxiety in the mother, and then this prenatal stress, and then we measured the level of cortisols in the maternal serum, and then we have measured the levels of different inflammatory cytokines. So at 1 year and 2 years follow-up, we have collected their DNA samples, and we'll be doing epigenetic studies, mainly DNA methylation. This is a targeted study on the inflammatory pathway related genes, stress regulatory pathway related gene, and monoimmune neurotransmitter pathway related genes. At the same time, we'll be studying child's internalizing and externalizing behavior, and those genes which will show differential methylation pattern will be subjected to gene expression studies. Okay. So we have, this is not yet completed. We have started getting very interesting findings. So this is the cohort. We have 157 data from 157 pregnant mothers, and then average gestational age was 25.31, and then the child recruited at 1 year, child recruited at 2 years and 5 years. These are the demographic profile of the children. So it's very interesting. At 1 year, we found that maternal cortisol level was positively correlated with inflammatory DNA methylation of the inflammatory gene as well as stress regulatory gene. The maternal level of inflammatory cytokines were positively associated with methylation pattern in the offspring of inflammatory as well as stress regulatory pathway regulatory genes. At second year, we found positive association between depression, maternal depression, and inflammatory methylation of inflammatory pathway related gene. Maternal cortisol level again with inflammatory pathway related gene, and maternal cytokine level again with inflammatory pathway related gene methylation. At 5 years, we do not have, I mean, we are in the process of collecting behavior data. So we have only biological data. Results are a bit different at 5 years. So depression, maternal depression showed negative correlation with DNA methylation profile of inflammatory gene. Cortisol also showed negative correlation. IL-6 and TNF-alpha also showed negative correlation. So we need to understand the dynamics and kinetics as we move on. Is same cohort being studied longitudinally for till 10 years. Okay, so that is Bangalore birth cohort study, and the third one is immune abnormalities in the neurodevelopmental disorders. So this is another very interesting study. In this study, we examined a comprehensive panel of immune marker, 48 immune markers in 3 different neurodevelopmental disorders, that is ASD, IDD, and ADHD. And we also compared the finding with typically developing children, 35 children. So the findings are very interesting. When we classified the immune markers into different functional group, we found that when it's compared between NDD groups as a whole and healthy controls, we found abnormality in the macrophage 1 and macrophage 2 data, and then IL-1 signaling, and then IRS. IRS is inflammatory response system. CRS is compensatory immune response system. And then when we observed the individual component, there is a very clear pattern across NDD and healthy control. Then we focused only on ASD. The findings are similar what we observed in the total NDD group. Then we compared the immune profile across 3 different groups, that is ADHD, IDD, and ASD. The most interesting feature is that the findings are similar across these 3 groups. So for example, IL-1 signaling is upregulated across these 3 groups. M1, M2 is upregulated across these 3 groups. When you look at the individual parameter, so it maintains consistency. These are different cytokines, and these are different chemokines. It also maintains consistency. So from these findings, from this study, what we observed that there is increased M1 and M2 macrophage responses. There is upregulated interleukin-1 signaling, and there is a deficient IRS and CRS ratio in neurodevelopmental disorders. The best take-home message from this study is that, and this is the first time we have shown that there is a shared immune basis across NDDs, that is IDD, ADHD, and ASD. And besides this, so far, I think only MRI studies have shown that there is evidence of increased neurogenesis in pediatric onset neurodevelopmental disorders. And from these studies, we also provide evidence on the basis of these factors. There is, evidence of increased neurogenesis in the neurodevelopmental disorders. Now we have shown that, immune pathways are altered in neurodevelopmental disorders, and immune pathways, they have tripartite crosstalk with circadian and sleep pathway. So we were interested to examine the role of sleep, immune, and circadian axis in autism spectrum disorders. We are just in the midway because there are a large number of genes from these 3 different pathways. So we have done an interim analysis, and we found that expression of the BML1, this is the master regulator of the circadian pathway. The gene expression of BML1 is downregulated in children with autism spectrum disorders, and this downregulation shows a negative correlation with sleep pathway gene, that is orexin. So as we move on, we'll get more data. I hope by next year we'll have some excellent data on the role of sleep, immune, and circadian axis in autism spectrum disorders. So the take-home message is that immune system, why there is so much of hype on the immune system, now we understand. And then what is the hope? I think our findings reflects that why there is so much of hope on the immune findings. So what is the promise and reality? The promise is that, of course, these immune markers and pathways can serve as target for the pharmacological intervention. And what is the reality? Actually, clinicians are treating. There is clinical trial on minocycline, aspirin, all these anti-inflammatory drugs on different psychiatric disorders, and they are giving encouraging results. Thank you. Thank you so much for your kind patience.
Thank you for the wonderful talk, Monijit. Excellent work. Any comments and suggestions?
Thank you for the talk. I wanted to ask you, where exactly does this neurogenesis occur? Is it only in the hippocampus or in other parts of the brain as well?
Here on the hippocampus. Yeah.
No, it's very interesting. So have you you now look at individual parameters, being the inflammatory cytokines or epigenetic modifications on. Have you actually tried to see if there are clusters? So if you do really a multifactorial analysis, if there are clusters that certain cytokine alterations may correlate with epigenetic modifications in completely different, unrelated genes, so to do a more unbiased analysis to ask if there are sort of subgroups that you could define based on the measures that you take?
Okay, so in the study which we published in Brain Behavior Immunology, actually we have applied neural networking and machine learning, and these help us to classify the patients with NDDs into different groups. One group having elevated TH1 signaling, another group is having deficiency in the IRS and CIRS. So that we have done on the basis of the immunological data. Basically, we can cluster the patients into different groups, and accordingly with respect to different severity also. So that we have done, but with respect to the epigenetic analysis, we have not done it because we are still gathering the data.
Thanks for the nice talk. At the beginning, you talked about this two-hit model, and I think there's this enduring kind of uncertainty in schizophrenia in particular, obviously other neuropsychiatric neurodevelopmental disorders also, about why there are all these early life, early development, in utero kind of risk factors, and then we see the frank onset of the disorder in adolescence or early adulthood, and obviously there's some soft signs sometimes present before that, but those are more variable and inconsistent. So, you talked about the two-hit model at the beginning, but then, most of the data you talked about kind of was more along the lines of there's this early developmental, inflammatory or infectious kind of etiology, and then it kind of sets things in motion that persist throughout this latent period of, presumably childhood and early adolescence. So I guess I'm just wondering what your thoughts are about this now, about whether, there is just sort of these ongoing processes during this latent period that don't end up manifesting until later on in life, or whether there really is a separate process that starts only later on in life that leads to disease onset. I hope that makes sense.
Yeah, I think the new hypothesis is that I mean it happens in a subset of organisms, individuals, considering the complex etiology of schizophrenia, and all these risk factors which happens across, prenatal and of course postnatal, they act in additive way, and it's really difficult to differentiate what sets these clinical manifestations in different patients. So I really do not have a clear answer on this.
Thank you, Monojit. Thank you very much. Now we come to the keynote address. And I would request Saurabh to introduce us.
My great pleasure to introduce Professor Peter Scheifel. Peter did his PhD with Kai Simons and started with a very seminal work on membrane trafficking, and then worked with Mark Teixeira-Levin, Tito Serafini, and that's how he entered into neuroscience and made a seminal contribution in our understanding of the synapse development and the synapse specificity. And he made significant work, significant contribution in the field, how alternative splicing actually regulates synapse specificity. And there are many, many aspects of that he highlighted in the field. And then recently, he started his work on autism, and there also he made very, very important contribution in our understanding of the neuromodulation by hormone and how that regulates social behavior related to autism. And he another part of the work that is very important and very new aspect, that how cholesterol distribution in cell type specific manner contributes to autism spectrum disorder. He has won many awards, just naming a few of them. He has received Human Frontier Science Program Long-Term Fellowship. He's an elected EMBO member, and he won the Robert Brink Prize of the Swiss Academy of Medical Sciences. Recently, he was awarded this Kavli Network Mentoring Award. With this short introduction, I would like to invite Professor Peter Scheifel for the keynote lecture. Please join me to welcome him.
My phone is in my pocket, but I haven't put it away. Okay, great. Thanks so much for the kind introduction. It's really a pleasure to be here. It's the first time I'm in Delhi, or near Delhi. Great. Okay, thank you. Yeah, and I thought I'd share with you some a bit older work and then more recent work that we are doing that I hope is most interesting to this group about our attempts to use rodent models to learn something about autism that possibly may transmit back to humans. And of course, you've heard beautiful talks already yesterday about the clinical picture of autism and heard about the heterogeneity, also about abnormal EEG signatures in relation to seizure disorders, and then this morning about genetics and its variability there. And I think one thing that I find really striking about autism is it really its variability, its heterogeneity. And there are some clinicians that we collaborate with that like to use the word autisms as a plural and really view autism as the umbrella term. But there's the suspicion that this may actually be quite a number of different disorders grouped together, and that we won't necessarily be able to find one treatment for autism, but possibly many different treatments to treat different subgroups. And coming back to genetics, I mean, this is like my take on this. This is mostly taken from a review from Thomas Bougeron from Pasteur Institute. But you've heard essentially very similar facts already in the previous talks, that there's a very strong genetic contribution for autism that comes from the twin studies with a concordance rate of 80 to 90%. And I think that is one of the things that actually got a lot of preclinical scientists attracted to studying autism, because once you have a genetic basis, you have a feeling you can actually attempt to model something and ask about functional implications of these genetic mutations. The models mostly focus on these very, very rare single gene mutations that are estimated to make up maybe about 10% of the total autism population. There's much less attempts to model these common variants that are having small effect sizes because it gets genetically quite complicated. And then when this review was written, there was an estimate of about 40% that were considered unaccounted. So where presumably there's also a genetic basis, but that hasn't been uncovered. And then, of course, also environmental factors that are acting on it. Then another part about genetics that is, I think, important is that many attempts are made to model these so-called syndromic cases. Fragile X and tuberous sclerosis, Williams-McDermott syndrome would fall into that group. And if these are really good models or not for autism, I think the future will still have to show, because they, of course, have very broad phenotypes that are going way beyond autism, even though a large fraction of individuals having these diagnosed with these syndromes are meeting the diagnostic criteria for autism. And then the pharmacotherapeutic efforts have actually largely been unsuccessful so far, and they've typically focused on neurotransmitter receptors and transporters or certain social signaling processes, so targeting vasopressin and oxytocin, but in the whole, applied to the whole population of idiopathic autism, those trials really haven't yielded too encouraging results. And so we're part of a big consortium in Europe called AIMS, I guess similar to the center that is here, even though the abbreviation stands for something else. And in discussions with the clinicians there, we've really been working towards ways of trying to do a rational subdivision of autism subtypes for therapeutic intervention, with the belief that you may actually need to do this type of stratification to be able to be successful in treatment. And now the question is then, what criteria do you use for stratification? If you take the genetics, it's challenging because, as I highlighted in the slide before, most of these strong high impact mutations, they're only present in less than 1% of the population. So then you get such a granularity that becomes, at some level, not feasible anymore to conduct a clinical trial. The other level to stratify, of course, is then at the level of, let's say, behavior, and then it's correlate the neural circuits and possible biomarkers that would help subdividing this into different groups. And then from the genetics, one can go also to molecular principles to say you can attempt to group genes that are affecting the same pathways or the same structures in the cell to thereby create a stratification. And this is essentially trying to combine these two aspects is something that we're trying to do in our preclinical studies, and then discuss this with our clinician friends to see if this is actually reasonable. And so then what do you focus on? The one domain that we decided to focus on is on social orienting and social reward, because this is something where we have a reasonable grasp on what type of circuits could be underlying this, and there are actually also ways to measure this in the human population. So this is some eye tracking data from the Ames consortium, where children are shown these natural scenes with situations. Here you see some social context in the face of that individual there. You can see how then mapping this quantitatively on the eye tracking, how eyes from typically developing children go back and forth and create relationships between the individuals that they see in these images. And this is still work in progress, but there's some signatures that are being seen now in autistic children that they actually differ, or subgroup of them differ substantially in how they're actually processing this type of information, how they're attending to the scenes that are being shown to them. And so this would argue then that there is possibly some alterations in the social orienting networks in the brain of the individuals that could underlie why they're responding differently and analyzing these scenes differently. And this is another task on reward. So this is a tablet-based task.
Let's see who wants to play. Yes, I'd like to play.
So you see this kid playing this.
No, I don't want to play.
What changed?
Getting disappointed occasionally.
Yes, I'd like to play.
And again, this is a task where they're actually attempting to see whether there are differences between typically developing children and autistic children.
I'd love to play.
And to really emphasize a social domain in this, they also created a task for monetary reward.
Yeah. Mm-hmm. Oh.
So you see, for this little man, the monetary reward actually triggers much stronger responses than the social, but that still gives you a way of seeing how one can to approach this in the human population. And so now, what is circuitry that could be underlying this? And the simplest system where there's really a huge body of evidence on this is the dopamine system. And with neurons sitting in the structure called the VTA, the ventral tegmental area, that project to different brain regions, and that have been implicated by imaging studies in the humans and by a lot of optogenetic and chemogenetic studies in rodents, to be contributing to social orienting, but also social reward. And this is just some of the references here that I put down, where, for example, this is a study where early study on imaging the activity in the projections, that the VTA-derived dopaminergic projections into nucleus accumbens are activated in social proximity, and that their activation is actually critical for social approach, regulates that. In this study, it was concluded that silencing this population actually didn't alter the approach to objects, arguing that there's really something social specific in the system. And this is another study, this is from the Malenka lab, demonstrating that silencing these projections impaired a social condition place preference paradigm. So where mice can choose to a compartment, one where they're conditioned with social conspecifics and the other one where they're in social isolation, demonstrating that activation of this projection would actually promote the preference being formed. And so this is some data from our lab using, these are very basic, very simple tasks. And we like that because you can actually nicely quantify them, either by automatic tracking with deep left cut of the animals, but you can even hand score them. And so this is one of these tasks for social orienting where we look at the response to novel conspecifics. So it's very simple tasks, also called the 5 trial interaction task. Where we do all of this, I should say, upfront in juvenile mice. This is all done in male-male interactions. The juvenile mice don't show aggression yet in this task. If you do this with adult animals, this becomes a big confounder, but actually works quite nicely at this age. So you have a mouse that's in one cage, and then you give it a conspecific that you add to the cage, and you simply quantify the time that they're interacting with each other. Then you're separating them, and after a short time interval, you put the same mouse back into the cage and again measure the interaction. You repeat this a couple of times, and you can see then that there's a habituation happening. So they kind of get bored by this other guy who comes to play with them because they've seen them so many times. And then if you add a novel conspecific, so this is another mouse that they've actually never seen or smelled before, then you get this novelty response and increased interaction again. And this is a very typical profile that we see in many different mouse strains. And this is this conditional place preference task that I briefly alluded to before. So here, this is a multi-day task where you have 2 compartments, and they differ by their floor mat, and they differ by their walls, and you condition animals together with conspecifics in one of these compartments. And then you have another compartment that's an isolation compartment. So they're put in alone in isolation. And then after multiple days of conditioning, you're then putting a mouse alone into this setup. You open these barriers here, and they can choose where they spend time. And then you can see that the mice nicely develop a preference for this social compartment. So they're exhibiting a social preference, and that's being interpreted as a kind of social reward that they're perceiving. So these are 2 assays that we've used quite a bit in our studies, and we're confident that this really depends on this projection from the ventral tegmental area on the dopaminergic neurons, because if you silence them during these tasks, you're actually impairing the behavior in both of these assays. So the way we've done it in these experiments is just chemogenetically. So we express this inhibitory dread gated by a creline selectively in the dopaminergic cells of the VTA. So this is virally introduced so this is done in adult mice. We've done the same thing in juvenile mice. We know that this is actually silencing the neurons. So if you do current injections, you really suppressing their excitability. And if you then give the ligand for this, so thereby acutely silence the population, you see that this novelty response here is for this habituation. This is the novelty response is strongly blunted. So normally it would go all the way up to here. And if you wash out this, wait for 1 day, then they're going up in the interaction again. So this is clearly dependent on this cell population. And this is the condition place preference task, where he is just quantified as a cumulative ratio where you see that there's a preference normally developing in the control animals, and that is abolished in the silent population. So then the next question is, well, now this is the circuit element, and that was basically replicating work that was in the literature already before. So now the next question was, does an autism-associated mutation, or do certain autism-associated mutations impair the function of this cell population and these tasks? And the mutant that we used quite extensively is the mutant in this gene neuroligin 3. This is one of these very rare but very high impact autism mutations in the population, where individuals carriers of this mutation, typically it's a copy number variation that's a full deletion of the open reading frames. and individuals either have very severe carnotype autism or Asperger's. And it's X chromosomal, so that means that male individuals with this mutation are actually complete nulls, which is also simplifying analysis then in the rodent model. And the gene encodes a protein that's sitting at synapses. It forms complexes at synapses. This is actually why we've been studying it in the first place before it was linked to autism. And we felt it's a good model because it meets a sort of, it's part of a whole cluster of genes that are encoding synaptic proteins and that all have been linked as high impact mutations to autism spectrum disorder. And I should point out that there are some articles that say autism is a synaptic disease, but this is only one cluster. And as you can see here, there's many high impact mutations also in RNA processing or in transcriptional regulation. So this clearly isn't only something happening at the synapse, but also carrying mutations elsewhere. So if you look at the global knockout in this neuroligin 3 and we do this social recognition task, the blue line here is the mutant, then you can see that they're completely defective in the novelty response. So they're initially interacting normally, they're habituating normally, but they completely lack the social novelty response. And interestingly, they're actually responding normally to novel objects. So this is not that they're scared of something novel or that they don't perceive something novel. If anything, they interact more with objects to begin with, and then they show a novel object response very clearly. And they're also completely defective in this condition price preference task. So they do not develop any preference for social compartment when we condition them over time. Now, this was a global knockout. And if there's a social specific phenotype, you could say, well, maybe they just can't smell. So they're not going to perceive the conspecific. So therefore, they're actually not responding to it. And to convince ourselves that this was really due to an alteration in this reward system in the dopaminergic cells, we used a viral RNA interference approach. So we injected viruses into the ventral tegmental area, into a DAT3 line, so to selectively ablate neuroligin 3 only in this population of cells. And then you can see here in this fine colored lines, so this replicates the phenotype that I had just shown you for the global knockout. And several of the other phenotypes that these mice have, they're actually a bit hyperactive and they have some motor alterations. Those are then not seen in this selective local loss of function, but this social phenotype is actually maintained. And now this was really what intrigued us, that they're not responding to a novel social cue, but they're completely normally responding to an inanimate object, a novel cue. And that's what made us think, well, maybe this has something to do with oxytocin, because there was data in the literature. There's a projection from the paraventricular nucleus. This is the area where all the oxytocinergic neurons sit, that projects to the ventral tegmental area, and that in a social context gets activated, releases oxytocin, and these dopamine cells in the ventral tegmental area carry oxytocin receptors. And then the application of oxytocin here, or the release of oxytocin here, increases the activity of these cells so that they're actually then releasing more dopamine into the nucleus accumbens. And so we then wondered whether, so there is some molecular evidence that neuroligin 3 actually binds to a scaffold that also links to G protein coupled receptors. And so we then wondered if possibly this mutation would alter the response of the cells to oxytocin. And this is just a bit of supporting data. So actually, when you do this task and you just give animals an oxytocin receptor antagonist just before the task, you're also losing this novelty response. So clearly, this behavior is oxytocin signaling dependent. So what we did is we labeled the subpopulation of VTA dopamine cells that are expressing oxytocin receptors and that are projecting to the medial shell of the nucleus accumbens. We labeled them with retrobeads that are transported back, and then we cut acute slices, did cell-attached recordings from these back-labeled cells. And you don't need to be an electrophysiologist to see that there's actually a massive phenotype in the mutant. So if you're bath applying oxytocin here, the wild type cells start spiking, and the neoligin 3 mutant cells don't respond at all. So you're completely losing this increased spiking of the cells when you apply oxytocin. So they can't respond anymore. And so that was very exciting because it fit very well to this behavioral phenotype. But then we tried to understand why this is actually happening. And this turned out to be much more complicated than we had hoped. So the fibers are all there, the oxytocinergic fibers, the oxytocinergic neuron density is normal. Oxytocin receptors are very hard to detect in the protein level because the tools are just not there and the expression is very low. The mRNA levels, if anything, is actually upregulated in the VTA-DA neurons. So none of that actually gave us an easy answer on why these cells would not be responding to oxytocin. And so we did a completely unbiased proteomic search for alterations in the ventral tegmental area. So we microdissected this region from control animals and from the mutants, and then looked what we're finding. And there's some proteins that are related to GPCR signaling, and that was consistent with work that we've done in the cerebellum on neoligin 3 before. But and then some components that are related to vesicle transport. But what really struck us was that we found this whole cluster of proteins that regulated to mRNA translation at the level of initiation, and the blue balls here mean that these factors are actually downregulated, so the EIF3 complex, and then core components of the ribosome itself that were upregulated in this mutant. And this was completely unexpected, but it was intriguing to us because there's actually a large body of evidence from many different labs. I think it mostly really started with the Fragile X studies by Mark Baer's lab that indicated that that alterations in mRNA translation homeostasis can be fundamentally important for autism spectrum disorders. And there's work from many labs, including the Sonnenberg and Klun lab, that has provided a lot more evidence for this. And now what was surprising about this is our mutant, of course, is a synaptic protein, right? And now we're finding changes down here in the mRNA translation in the cell. And of course, there is ways to rationally connect signaling from the surface, in particular through the TOR pathway, to translation initiation. But given that the translation had been linked to autism in these other models, we really wanted to explore this more. This is just the same data I showed you before, just plotted in a different way. This is the log 2-fold change in the protein level in the mutant over the wild type. And you see here all core ribosomal proteins plotted, and you see this clear right shift away from the majority of the proteins detected here. It's a modest shift, but what made us confident that this is likely meaningful is that when we plotted the proteins of the mitochondrial ribosomes, they're actually not showing the same thing. We then used a method to measure in situ the rate of mRNA translation. So this is a method called FunCat that was developed by Aaron Schumann's lab. And what we could see with that in the dopaminergic cells of the VTA, there was a clear increase in the rate of translation. And so that fit this idea that this change in ribosomes actually precipitates a change in translation. But now the big challenge was to how you can actually convince yourself that this matters. Is this an epiphenomenon, or is this actually fundamentally important for the phenotype that you see in the mice? And so to test that, we chose a pharmacological approach where we inhibited a key kinase called MAP kinase interacting kinase, or MINC in short, that is gating translation initiation. And MINC phosphorylates this factor EIF4E, which is binding to the cap, and has been implicated in assembling the initiation complex and then initiating translation. And there was some other genetic evidence suggesting that there's a connection between MINC activity and Fragile X phenotypes. And so we then teamed up with a medicinal chemist, Kasum Nakro, who was back then at the Experimental Therapeutics Center in Singapore. And he had been working on MINC inhibitors for oncology applications. And we then built on some of the scaffolds that they had to make MYC inhibitors that are more brain penetrant, so that we could actually apply them in our model and ask whether modifying MYC activity would affect the translation rate in our model, but then more importantly, the autism-related phenotypes. And this is some of the data shown here. So we're inhibiting MYC, which is gating translation initiation. And what we can see is that when we treat animals just sort of subchronically for 26 hours with a MYC inhibitor, we're actually normalizing the levels of the ribosomal proteins in this model. And more importantly, we actually could rescue the oxytocin signaling responses. So this is the physiological recording experiment that I showed you before, where the vehicle-treated neurogen-3 mutants are completely flat. They don't respond to oxytocin, but the drug-treated animals increase the spiking. I should say during the recording, there's no more inhibitor present. We just treat the animals before, then we cut acute slices, and then do the physiology. And then importantly, also the behavior is completely rescued by this. So the open circles here, the vehicle-treated animals that habituate don't show the novelty response, and the drug-treated animals show this strong increase here. So then to summarize what I've told you so far is that we focused on social recognition in mice, which I guess it's still debatable if that really replicates or is it translates into social orienting in a human being, but this is at least something we can do in the rodents. Then we've seen that this depends on dopamine signaling, but also on this oxytocin signaling onto the dopaminergic cells that then increase their firing and activate nucleus accumbens and drive this social orienting. Then we found by looking at a mutation in the synaptic risk gene that there is a convergence between protein synthesis and oxytocin signaling, and that inhibiting this kinase could rescue the physiology, but also the social behavior in the animal. And now where do we go from here? So the one thing that's really been playing a big role in preclinical work on neurodevelopmental disorders is this question about translation, too much or too little translation. And I think when this was proposed originally by Mark Baer's lab, they already were fully aware that this is way too simple to actually account for what really matters, right? That it's a bit too trivial to think, oh, there's just too much of something. And there's a lot of work actually coming from non-neuronal systems, from yeast and also from cultured fibroblasts that put forward that it's actually, yes, as an epiphenomenon, if you measure total translation rate, you may see this as more translation, but that what really matters is when you have different ribosome concentrations, that this would affect how well certain mRNAs are being initiated for translation. And that would depend really on the structures that are in the 5' UTRs of the RNAs, and that there are some RNAs that are initiation limited. And so if you have more ribosomes, you actually make more protein. And there's other RNAs that are elongation limited. And if you have more ribosomes, you will actually get less protein, because on a very long transcript, ribosomes will tend to collide with each other. And that actually then leads to termination of translation and the degradation of the mRNA. So while we're reading out some really high-level change in the rate of overall translation, what likely happens in the cell is something like this, that there's certain RNAs that are particularly affected, and some will actually go up, where the proteins will go up, and for others, the proteins will go down. And I don't really have the time to tell you much about this, but we've done a whole project now on ERF3G. So ERF3 is one of these translation initiation factors that were altered in our neuroligin-3 model, but there's actually also mutations, high-impact mutations in patients in this ERF3G subunit. And so this is a common component of translation initiation. But when we mutate this, we actually see very selective changes in the proteins that are deregulated here. And what we discovered in that work is that it's actually the presence of so-called upstream open reading frames. So one of these filters, one of these structures in the 5' UTR that gate translation initiation that determines if the protein will actually be going up or down. And that there are RNAs that have very high EF3G binding normally in their upstream open reading frame. Those are the ones that are heavily affected by this mutation. And those tend to actually encode components of the synapse. So this would be an example of taking a common component that regulates translation, precipitating very selective effects in mRNA translation. And this actually then brought us back to the oxytocin receptor and the riddle why the cells didn't respond to oxytocin anymore, even though the oxytocin mRNA levels were completely normal. So we did a large project in the lab where we actually used PacBio. So this is long read RNA sequencing where you read the entire mRNA and you can very accurately assign transcript isoforms that are expressed in different neuron populations. And what we discovered using this method is that the oxytocin receptor actually, there are 3 different transcription start sites that make 3 different transcripts that are shown here for the mouse, but the same as equivalent is found in the human. And what makes this interesting is that they actually only differ in their 5' untranslated region, and they differ in one, and the major form actually containing these upstream open reading frames that I just mentioned before. It's conserved in human, also in the prairie vole that's been used a lot for these studies on oxytocin signaling, and in the mouse. And they are sitting right in this area where there's a lot of methylation. So the green ticks here are methylation sites, and also overlaps with an antisense transcript that we discovered in this long read sequencing experiment. And so our hypothesis was that this could actually gate how much protein you put out, and this could be the reason why we see a loss of oxytocin responses in our model when there is translation rate being altered. So just for if there are any translation aficionados, so this is CAGE-seq, so this is transcription start sites, and you can see here there's a massive peak here driving this isoform, and that massive peak here driving this isoform, smaller one driving this one. This is ribose-seq, so RNA footprinting, ribosome footprinting that we've done, and this shows a clear site where ribosomes engage that is sitting here. So this is a so-called upstream open reading frame. And just for people who don't think about translation a lot, I just cartooned upstream open reading frames here again. So these are, so normally in an RNA, when you have an open reading frame, there would be the ATG here, and you would get translation initiation here. And this is making the protein that the gene is supposed to encode. What upstream open reading frames are actually sequences that also have a translational start codon and frequently a stop codon as well, that can actually attract ribosomes to initiate, but they're not actually driving translation of the actual gene product, and thereby they're regulating how much the ribosome gets access to this primary open reading frame. They can actually have positive but also negative impact. In the positive case, this would be a case of reinitiation, that the ribosome initiates here, it starts translating, it stops translating, but the 40S stays attached, keeps scanning, and then it's reinitiating here. And then there are other cases that are described mostly actually in yeast, that the ribosomes initiate and then they fall off. And then thereby the upstream open reading frame suppresses output of this primary. Now this is present, this kind of signature is present in the oxytocin receptor, and the question we asked, does this actually matter for anything? And so we made a mutant where we only put in 2 point mutations that are mutating the upstream open reading frames that are seen in the oxytocin receptor. So the coding sequence of the gene is completely unchanged. It's exactly the way it is. There's only 2 point mutations in the upstream open reading frame. When we do that, what we found is that the RNA levels of the oxytocin receptor in the mouse brain don't change at all, but the protein levels were reduced by about 75%. So these small mutations in the non-coding regions gave a massive impact on protein levels. And then remarkably, when we now do our social interaction assays, they essentially behave like Neuralink-3 knockout animals. So they're not responding to the novel stimulus anymore, and you're completely losing this novelty response. So our hypothesis, therefore, is that actually this changes in translation that we have in our Neuralink-3 model, but likely also that exist in other models, can actually have a major impact, not on the amount of protein globally that you output, but that they are very specific for certain transcripts that are containing these filters in the 5' UTRs that are gating mRNA translation. And so this just adds to the evidence from genetic studies that's out there. So here in blue, I've just highlighted risk factors, rare high impact mutations for autism that have been described in other components of the translation initiation machinery. I think our contribution there is now to demonstrate that even distant mutations in a synaptic component, if they act in a common pathway to drive translation initiation, can actually have very similar effects on the translation regime. We think this is important for neurodevelopment because this translation regulation is really key for synaptic plasticity and for building networks during development. And that possibly then targeting this pharmacologically could actually provide some benefit in a specific subgroup of individuals. And with that, I just want to acknowledge the lab, and the people who've done this work. The work on the UORBs and oxytocin receptor was done by Julia Odermatt, a very talented PhD student in the lab. All the long-read sequencing that I only touched upon very briefly was done by Dietmar and Louis. He's a purely computational person, and he's doing all the bench work. Raoul did the work on the EIF3G, he's a postdoc in the lab, and mapping the selective impact on translation. And then I realized last night I must have been too tired to put in the picture of Hannah Hornberg, who actually did the work on the Neuralink-3 mutant. She has her own lab now in Berlin, where she studies social behavior, and it's really been spearheading the beginning of this work. Our collaborators, then I want to thank Swiss Chocolate that keeps everyone happy, as you can see, and our funding sources, in particular the AIMS consortium that support the autism work in the lab. And thanks for your attention.
Questions?
So which type of PI3K do you think is connected to the oxytocin receptor signaling in this case?
Which type
of PI3K? Which class of PI3K?
Of the PI3K, that we don't know yet in the neurons. There is work from non-neuronal cells that actually even suggests that the G protein that's coupled can differ depending on the dose of oxytocin. And so that makes us think that we really have to look at this in a cell type specific way, and we haven't done that yet. But we've only looked at more downstream at AKT and SXK signaling readouts.
Right. But that signaling has to happen in the cell body.
Most likely it has to happen in the cell body.
You need to transport those signaling complexes from the postsynaptic.
Yeah, so I think there is a whole question still in terms of the oxytocin and so I drew the oxytocin receptors near the synapse, but the subcellular localization of the receptors is actually unknown. We've made 4 or 5 different knock-in lines to put a tag into the oxytocin receptor, and so far they've always interfered with the expression level. So we are not really sure where it is.
And is there any neuron subtype where you think this effect will be manifested most, or generally?
Well, for the linking the expression level of the oxytocin receptors and the loss of function and behavior phenotypes, it's most likely, so it has a major impact in CA2 in the hippocampus. There it's in both the PV and the pyramidal cells. There are cells in the prefrontal cortex that are also expressing high levels of receptor, and this has also been implicated in these types of behaviors. And then the dopamine cells in the ventral tegmental area.
Yeah.
We are now shifting a bit to CA2 because the VTA-DA neurons, it's just for anything more cell biologically, they're so heterogeneous and they're so few, which makes it quite challenging. And then CA2 is
So
a
the
bit
CA2
easier.
is mostly bipolar, I suppose. Or CA2 neurons are mostly bipolar. They have a single dendrite or multiple dendrite.
Well, they look like pyramidal shaped cells, similar to what the CA1s look like. And there we see dense covesicles with the oxytocin in proximity, but we're still looking at whether some of this release is actually if it's purely volume or whether there are actually also more sort of active zone dependent local release sites. And it looks like there is some active zone release as well.
I would suspect, yeah.
Yeah.
Thanks.
Thank you.
Great talk, Peter. Usual. I have a question. In a human settings, the oxytocin tocin connection we are looking at, you think it's coming from the type of the attachment between the parents and the kid? Because the oxytocin level will be driven by the parents interacting with the child, right?
So yeah, I think there's a lot of evidence from many different systems, right? That social contact and physical contact trigger the release. There is also quite some evidence in mostly coming actually from the voles that the receptors also dynamically regulated so that you could essentially elevate or decrease it. But yes, so the idea would be that this is triggered by social contact as well.
And the other question is that other proteins which are very susceptible for this kind of autism spectrum, like synaptic protein you are talking about, Shang, Homer, they are not specific to the circuit, this circuit, right? They are all over the place in brain circuits. They're regulating synapse position, synapse function. So it's that these mutations plus other things makes this thing.
So yeah,
just putting
also,
everything together.
Also the neuroligin 3 is just about everywhere. So looking at where the neuroligin 3 is expressed doesn't really tell you where to look for the phenotype.
Right.
And I certainly don't want to reduce the neuroligin 3 phenotype to only this oxytocin signaling component, because as I showed you, or I touched upon that the global knockout has a lot of additional, has also motor phenotypes. Some of those are actually coming from cerebellar alterations and neuroligin 3, and those are almost certainly not related to oxytocin signaling because there is no receptors in the cerebellum. And I think that the same will be the case for Shank mutants, right? I guess there's data that SHANK3 in the muscle is playing an important role for the hypotonia that you observe in the individuals, but it will unlikely explain the social elements of the phenotype, right? And I think that's in the end, when thinking about a intervention, right, then the precision of the intervention somehow I do think has to be made aware of the context, what kind of behavioral phenotype you're actually trying to target. And you may, and I think this is a whole other discussion that I'm a total bystander to, as to what is if you take a composite score, which is typically used for assessments, right, in the clinic, if you take a pure neurobiology view at this, you would actually say that certain interventions will only move one of those composite measures, but not others, because it's selectively acting on a certain circuit, and thereby it will selectively move your social reciprocity score, but not other scores. And I think this is a whole question how one actually can actually interpret trials, because if you may not move your composite score, but you actually may have a true benefit for the individual. Right?
Thank you.
So all of our footprinting data is not done subsynaptic, but is done global. So we cannot speak to what happens at the synapse or the total. I don't think we say, so I don't think we have looked at it like this. We've mostly looked at on what transcripts do footprints go up and down. I don't think that, though I think overall the number of gene products that we find in the footprinting experiment, the total number with regards to how many genes do we see, doesn't change in the ER3G mutant. Yeah, so no, there we don't see a change. Yeah. So it's really selective as the certain transcripts, the footprints going up and for others going down. Yeah.
Okay, any other question? So I have a quick question actually. So you have looked into different developmental stages, each correspond to the like very early childhood, adolescent, young adults, like that. And then at what particular developmental stage this oxytocin signaling is triggered, and whether it is very specific for certain developmental stages, and associated translational control as well.
So, I mean, there is quite a bit of work from Ben-Ari on oxytocin playing a role very early, just after birth, right? We've not looked that early at alterations. And we've essentially just, for the oxytocin signaling response, looked at one time point. I do think that, and it's something we're starting to do a bit now with the intervention, I do think that the time period when you treat is very important for outcome. And because there are clearly critical periods of development where the sensory systems assemble and where changing the signaling regime will have a long-lasting impact, right? And we've done some experiments now where we treat it. It's a bit tedious or complicated because whenever you do a daily drug application in a rodent model, you're also perturbing the maternal care. And there's a lot of knock-on effects. So your vehicle effects are substantial. And so it took us a lot of time to actually do this in a way that we didn't produce a massive phenotype simply by daily perturbance of the nest, right? So it's not an easy experiment. What we have seen though, it's still a bit preliminary, but that when we treat the animals from postnatal day 10 to 20, and then stop treating with the MYC inhibitors, they still show a strong behavioral improvement at 60 days old.
It will be better, actually.
Thank you. So I think that really speaks towards the developmental periods that are critical and that are actually then producing long-lasting changes. And that comes back then, of course, to early diagnosis and early intervention, which I think there's a lot of evidence for that for the behavioral intervention, that the earlier the better, right?
Okay, so
yeah, really nice talk, Peter. A couple of questions. So one is, I found this, mechanism whereby the levels of ribosomes, have different effects on different transcripts, and this kind of effect on the oxytocin. Really interesting.
Yeah.
Can you think, are there other kind of situations in which this contributes to variability in oxytocin receptor, expression that is normal, that is adaptive, or engaged by other pathological processes? I'm just curious if this is something that these neurons use to regulate oxytocin receptor levels.
So I think it can, this gate for translation gives a good possibility that you can rather acutely elevate the responsiveness of the cell to oxytocin, right? That's actually why we got excited about this in the first place. There is data from the voles that mating and isolation modify oxytocin receptor levels. This is still based on sort of radioligand binding, so it doesn't really have cellular resolution, but that's something we're working towards, that we actually can capture that. The other level where you can get more long-lasting alterations is actually, and we're still also sorting this out, is at the level of methylation at the promoter, because that will produce different transcripts, and only one of these transcripts has the translational gate, and the other transcript is actually constitutively made. And there's quite a bit of literature on early life adversity, changing methylation of the oxytocin receptor locus. And so that would then give you lifelong oxytocin receptors expressed with a different regime or at a different level. And that's another direction that we're going into. So I well, belief is not a very scientific book. I hope that this is actually having a broader physiological function. Yeah.
And then maybe just a quick related question. When you guys were patching onto different or recording from the different dopamine neurons in the VTA, is like everything you said only true for like, you know, the neurons which project to the nucleus accumbens, or is it true for other dopamine neurons in the VTA that project cortically?
So the selection of the neurons that project to the medial shell is simply that that's the best predictor for the cells actually being oxytocin responsive. And we've also done recordings on the total population, but then the fraction of cells that in the wild type responds to oxytocin is lower. There may very well be another population that also responds to oxytocin that projects to, I mean, it would be very interesting to the tail end of the striatum if those are actually expressing this as well. But we don't have a good molecular marking. We have not done this systematically. In the single cell sequencing data, it doesn't really tell you because the transcript levels are so low that you don't see the receptor in the single cell data. One other element in this, and we have not pursued this, the GABA neurons in the VTA also express oxytocin receptors. And so it's conceivable that volume transmission of oxytocin in the VTA will actually increase the activity of some DA neurons and suppress the activity of others through those GABA neurons. But we have, I mean, there is a Russian lady whose last name I'm always mispronouncing. She worked with Bernardo Sabatini, Kozorovitsky. Yeah, oh, you know who I'm talking about. She actually discovered this GABA neuron oxytocin receptors, and that's really her work that I was referring to now.
Yeah. Any further question? Okay. If there is no further question, let's thank Peter one more time. And first we'll take the photograph just upstairs of this auditorium. There is a staircase, you can go up. And then we'll come back to the auditorium and continue to this, the following talks. And there will be tea outside. And then you can bring the tea and food here inside. Lunch will be there at the end, after the photograph. So after the photograph, you come straight to the auditorium. We'll start the talk. There will be tea. You can go as and when you like to have the tea.
Saurav, can you hear me? Saurav.
Yeah.
Can you hear me?
Yeah, I can hear you very clearly. Tell me, Dipanjan.
Yeah, so my talk is the next one. I just want
So what we are doing, we're running a little bit late.
Okay.
Can you give the talk at 1 o'clock?
Yeah, sure. I can give the talk at 1. No problem.
Then we will adjust the time. It's better.
Okay, fine. I just wanted to know. I mean, I just thought about knowing the time,
right,
so that I can, find a good spot for connecting. Yeah. Okay.
Yeah.
Okay.
And it will be between. We'll start on 1 to 1:10, something like that. Actually.
Okay. Fine. Thank you. So I I'll just log out in that case. I'll just log out and I'll connect back before 1. Yeah?
Before 1. Perfect. Yeah.
Okay.
Dhananjay, are you online?
Hi, Anando. Yes, I am online. Can you hear me?
So why don't you check your slides with Kedar, who is helping with the setup?
Okay, sure. I can do that. Can I share my slides?
Just 2 minutes. I'll call.
Okay, just hang on there for a minute. Yeah.
Okay, okay, sure.
Another person is checking the slide, then we'll do that. Yeah.
Absolutely. No problem.
Hello.
Hi.
Hi, this is Kedar.
Hi, Kedar.
Dr. Yes, Dr. Dhanya, you can share your slide.
Okay, okay. Let me do that. Okay, are you able to see my screen?
Not here, and yeah, 9.
Okay.
Now it is visible.
Okay, and now I will put it in the presenter mode. Is it
Yes.
there?
Yeah.
Okay, and are you able to see my pointer?
Yes. Just
Excellent.
just move your slides and we can check it is moving and properly.
Yeah. So that's the next slide.
Yeah, next slide is what is the cell type, right?
Yeah, what is a cell type? Yes. And then cerebral cortex is
Largest complex and evolutionary recent.
Yes. Then one after is understanding organizational principles.
Yes. No, yeah, it is moving. There is any video, any?
It's all animations. There is no video as
Okay.
such. Okay, then direct and indirect neurogenesis.
Yeah.
Okay, great. And then fundamental unresolved questions.
Yes.
Okay, then TBR2 captures intermediate progenitors.
Yes.
All right. Fate mapping.
Yes.
Okay. Neocortex role of ING.
Yes.
Okay. Direct and indirect neurogenesis.
Yes.
Okay. Then directly born FASF2 expressing.
Yes. Right.
Great. I think I can also see your screen, which is good.
Okay.
Yeah, direct and indirect neurogenesis again.
Yeah.
Fundamental unresolved questions.
Yes.
Okay, then cortical neurogenesis, inside out pattern.
Yes. Right.
Then laminar deployment.
Yes.
Okay. Intermediate progenitors, specify. Then distinct neuron types generated within there. And then sequential specification.
Yes.
Fundamental unresolved questions again. Role of progenitor heterogeneity.
Yes.
Okay. Fundamental questions again.
Yes.
Okay, and then the acknowledgement slide.
Okay.
Good. Okay, great. I'll just go back and I'll just keep it at this, at the first slide itself.
First slide, keep in sharing, and then actually right now all went for a photograph, and then after that the session will start.
Okay, so it'll be another 10 minutes, right?
Yeah.
Okay. So I'll keep it here.
Yeah. Okay. Thank you.
Thank you.
Hello. Let's start the session, and speaker is already ready. We really have to start. Okay, the next, please come inside. You can bring the tea and coffee, whatever you would like to have. Acha. No, I will bring them. Please come in, please come in. Car will be there, just 1 second. Yeah, you just go there. And, yeah. I'm coming. Come inside. अंदर आओ, बात करो जितना कोई प्रॉब्लम नहीं है, बट चालू करना पड़ेगा. अंदर बात करो. Please come inside. Okay, so the next speaker is also online, and it's Dhananjay Wilgol. He's from Duke University. Earlier, he did his postdoc from Cold Spring Harbor, and he'll be joining us as assistant professor starting from January 2025. Dhananjay.
Hi, sorry. I think I got kicked out of Zoom for a minute.
Share your slide.
Yes.
Yeah, a full screen, and then it's, yeah, perfect. So 20 minutes is your time.
Sounds good. Thank you, Saurabh, for the introduction and for inviting me to present at the Foundation Day Symposium. It's a great honor to be here, and I hope I can help in organizing this next year. Today, I'll be talking to you about generating neuronal diversity from progenitors in the cerebral cortex. So there are two terms here, neurons, which are a major kind of cell types, as we all know, and cerebral cortex, which is the largest, one of the more complex structures in the mammalian brain, which I will elaborate more on in the coming few slides. So what is a cell type? Cell types are cells that share morphological and phenotypic features that are rooted in development and give us a peek into the evolution of a particular cell type and then eventually the structure. And the importance of cell types is because each organ and organ system is very complex. It gives us a parts list to understand the complexity, but at a piece by piece information. It facilitates genetic access by giving us molecular inkling or inroads into it, and as well as in function of development, as well as function and eventually evolution. And the third and the most important part is what we all eventually aim to do is targeted therapy, which in the field of cancer immunotherapy has already been established. I'm going to talk to you broadly about the cell types in the central nervous system. What you are viewing here is schematic of the central nervous system neural tube with the forebrain or the telencephalon here, the diencephalon, midbrain, hindbrain, and the spinal cord. The focus of today's talk will be the forebrain and particularly the cerebral cortex. There are several broad categories in which cell types can be divided. First is neural versus non-neural. Cell types can be defined from where their origin is. And so neurons, astrocytes, oligodendrocytes are all neural. And non-neural include blood vessels, so endothelial cells, and immune cells, and so on. Within the neural category, there can be neuronal, which is the neurons, and non-neuronal, which include support cells and other cells like astrocytes and oligodendrocytes. And neurons themselves can be divided into inhibitory GABAergic neurons and glutamatergic excitatory projection neurons. So what you're viewing here is the schematic of this mouse cerebral cortex, which shows here several areas in color. So there are primary motor cortex, primary visual cortex, higher order secondary somatosensory cortex, and so on. These areas communicate with each other and with outside world to form a representational map of both the internal and the external world of the animal. There are two major cell types that are present in these areas and in the cortex. The excitatory glutamatergic projection neurons are those that project large distances and carry information from one region to another. And the inhibitory GABAergic interneurons are locally present and modulate the responses of projection neurons. Both these neurons are born from the central canal along which the entire neural tube is established. The central canal is known as the ventricle, as we all know, and has zones of cells that line the ventricle, shown here in red and blue, known as the ventricular zone or the neuroepithelial domain. Neurons that are excitatory or glutamatergic are generated from this dorsal region known as the paleal ventricular zone and migrate radially outward to settle into the cortex. Inhibitory interneurons, on the other hand, are the ones that are born from this ventral domain shown in blue and then migrates tangentially into the cortex to sit between and modulate the responses of projection neurons. Now, these cell types and their development is conserved across the entire mammalian and, in fact, vertebrate lineage, although their structure is different from mammals to non-mammals. But as you can see, the areas also shown here in red and blue are conserved. So like the basic body plan is conserved across all vertebrates, the basic cortex plan is also conserved across all mammals. And this brings me to why I want to study a developmental genetic approach, since all this information is encoded in the genome, that helps me understand the organization of a cortex. Now, focusing on the excitatory projection neurons, how has the field defined projection neuron types? There are broadly different ways, and classically, they are divided into their laminar location. So mammalian cortex is 6-layered and neurons sit from layers 2 through 6. They're also divided based on which areas they are part of, so visual cortex or the motor cortex and so on. The more important definition to us is the projection type because it's a proxy to the function. And so based on projections, there are 3 broad categories in which these neurons have been divided. The corticothalamic neurons, shown here in orange, sit in layer 6 and project to the thalamus. And we all are aware what the thalamus is. It's a relay structure and allows for information processing from the senses to the cortex. The pyramidal tract, popularly known as the corticofugal projection neurons, are shown here in blue, and neurons for the corticofugal project to all the way down to the spinal cord and intermediary structures such as the thalamus, the superior colliculus, and the pons. And the third and the largest category of neurons is known as the IT or the intratelencephalic, where neurons project within the telencephalon, so the front region of the brain, whether it's different types of cortices or to the striatum or to the amygdala. More recently, with the advent of high throughput molecular technology, there have been identification of molecular types, and there is a correlation between molecular types as well as projection types that has been established. Now, this vast diversity of neurons is actually all produced by specification in progenitors that underline the ventricle here, as you can see. And all this gives rise to the diverse types of neurons. So what I want to understand is what's the relationship between the developmental origin, the transcriptomic types, and the functional types, in this case, the projection categories. In the mouse, which has been the focus of my interest so far, and I want to explore further in other mammalian systems, including humans, the neural tube schematic, as you can see, where you're viewing a top-down view, has 2 different types of progenitors. The principal progenitor cells are known as the radial glia, shown here in red, that have a radial process and divide once to give rise to itself and once to give rise to a neuron that then migrates along this radial scaffold to settle into the cortical plate. This is known as asymmetric neurogenesis or direct neurogenesis because neuron is born directly from radial glia. At a later stage, radial glia also give rise to a more specific progenitor type known as the intermediate progenitors, which then divide to give rise to 2 neurons in most cases, which also use this radial scaffold for their migration. This is known as indirect neurogenesis, shown here in green. Note how radial glia are present throughout the central nervous system and generate neurons for the entire central nervous system. However, intermediate progenitors or indirect neurogenesis generates neurons for only the forebrain region and vastly for the embryonic telencephalon, which is what has expanded the most across evolution. This dendrogram shows how TBR2 positive cells away from the ventricular zone, in the subventricular zone, started appearing in certain reptiles and birds, but particularly expanded in mammals. this expansion continued in non-human primates and humans, such that there were more numbers as well as types of intermediate progenitors that correlates with the cortical size and complexity. So the question I set out to ask was, do intermediate progenitors only amplify the neurons that are produced by direct neurogenesis or directly from radial glia, or do they also diversify into new neuronal types that are produced from radial glia? And the second question, which I will address, is what is the relationship between the process of cortical neurogenesis and the neuronal types as well as circuit assembly through these progenitors, specific progenitors that are intermediate progenitors? So there was a need for methods that would enable us to track progenitors all the way to neurons that can integrate into a circuit. And so what we did was we made a TBR2 specific flip line. So TBR2 is the driver, and we use flipase recombinase just like the Cre recombinase, included a flip-dependent RFP reporter. And here's what we saw. You're viewing a coronal section or sections which are taken from the front to the back of an embryonic day E10 when neurogenesis begins. For people who are new to mouse, mouse has a gestation period of about 19 days, and mid-gestation is when cortical neurogenesis starts. Note how the RFP positive cells are not in the ventricular zone, but away in the subventricular zone and are round in morphology, indicating that we targeted the right set of progenitors, which were intermediate progenitors. When we looked at the adult of the same animal around postnatal day 30, we see that there are neurons from this lineage across all cortical layers, layers 2 through 6. They generate axon projection types for the IT type or the intratelencephalic, which can be seen in the corpus callosum and the striatum. The PT or the pyramidal tract, as you can see axons in the pyramidal tract all the way down to pons and the spinal cord, and neurons of the corticothalamic or the CT type that project to the thalamus. Next, we wanted to address whether we can see direct and indirect neurogenesis being produced in the same animal with a cell type resolution. And so we resorted to this reporter that we designed known as the intersection subtraction reporter, where the stop cassette is between two LOXP sites. And when a Cre acts, in this case, a radial glia specific Cre, it removes the stop cassette and allows for the expression of RFP in progenitors as well as neurons that are directly born. At a later point, when TBR2 starts expressing in intermediate progenitors, the flip from the TBR2 flip excises the RFP cassette between the two FRT sites and allows for the expression of GFP. And so what we will see is, this is a coronal view at mid-corticogenesis. You can see how RFP positive cells are radially aligned and are indicative of radial glia, whereas it's missing from the GFP channel, and all the GFP cells are present in the subventricular zone or in the cortex, indicative of intermediate progenitors. We wanted to look at the cortex at postnatal day 30 from the EMX1 Cre cross to TBR2 flip with the intersection subtraction reporter, which shows labeling of neurons both from direct and indirect neurogenesis across all the cortical layers, whereas where maximum proportion of neurons are produced indirectly, which is 78%, indicating that there is amplification through indirect neurogenesis. And we wanted to look at the broad projections, again, both direct and indirectly born cells projected to all the different categories, the intratelencephalic, the pyramidal tract, as well as the corticothalamic. Now we wanted to see that at an individual level of IT, PT, and CT, do we still see the 78-22 distribution, or is it different, which will indicate whether it is diversifying or not? And so we made use of Cre driver lines that we created for different types of IT lines, the PT or the pyramidal tract, and the CT or the corticothalamic, which are shown here in blue. CUX1 labels only cortical neurons, and we can see that 100% of these neurons are born through indirect neurogenesis. Plexin D1 labels both cortical as well as corticostriatal neurons, and 100% are also born through indirect neurogenesis. Whereas there is a significant proportion of directly born cells, about 24%, which are present in LHX2 Cre-ER, which labels neuron from layers 2 through 4. And you can see how RFP and GFP positive cells are sitting right next to each other. When we looked at the PT type, we see a 50-50 production from direct and indirect neurogenesis in the PT. And the TLE4 CREA shows that corticothalamic neurons are almost entirely born from direct neurogenesis, showing that indirect neurogenesis has a differential contribution to intrateloencephalic, followed by pyramidal tract, and followed by the corticothalamic neurons. This indicates diversification at the level of this progenitor. Now we wanted to look at these category of neurons that have two different neurogenetic pathways that produce two neurons sitting right next to each other, are very similar in morphology and may even project to the same targets. But what makes the difference? So we wanted to look at projections, and I'll give you an example of FESF2 CRE-ER. And what we see is neurons for FESF2 CRE-ER project to the striatum, the spinal cord, as well as the thalamus, and we see both RFP and GFP positive cells, shown here in yellow, producing axons for these structures. We used a retrograde label, which is CTB, and injected into the posterior nucleus of the thalamus, as well as other structures. The posterior nucleus of the thalamus, and analyzed after 10 days. Here's the injection site, and we analyzed in two different regions of the cortex that project to this nucleus. And we found that majority of the neurons that project to the higher order thalamic nuclei are actually directly born, and therefore FESF2 expressing projection neurons project preferentially to higher order thalamus, whereas those that project to the spinal cord all the way down to the PT tract have equal propensity of directly and indirectly born cells that project there. So what I showed in this part of my work is that direct neurogenesis generates all three major neuronal classes of projection neurons, whereas indirect neurogenesis generates novel projection types and diversifies within each of these categories, particularly the intrateloencephalic neurons. And we also saw that their projection differences were pretty evident in terms of ipsilateral cortex projecting neurons, in terms of striatal projecting neurons, in terms of even thalamic projection neurons, showing that there may be indication of them being differentially involved in neural subnetworks. So we found a fundamental lineage-based framework to understand cortical circuit assembly and evolution. So next I will move on to what is the relationship between neurogenesis and circuit assembly. And so what Angevin and Sidman did, and this is a classic picture from Cortical Development 101. If people have studied cortical development, they will know that there is inside-out neurogenesis in the cortex, such that neurons that are born for deeper layers are born first, followed by the mid layers and followed by the superficial layers, which was shown by this experiment done by tritiated thymidine injection, which is like BRDO, a thymidine analog, and incorporates itself into the S phase of the cell cycle, marking the birth of a neuron, and therefore a birth data. And they report how there are broad strokes of deep layers, followed by middle layers, followed by superficial layers, born throughout neurogenesis, across neurogenesis, which took shape of the central dogma of cortical neurogenesis, such that neurons that are born for layer 6 are born first, followed by layer 5, followed by 4, and then layers 3 and 2. At some point, some reports also suggested there were more than one layers that were being born at one time, and hence it sort of deviates from what is the strict inside-out neurogenesis. And the reason we think are the following. One is that there was both projection neurons as well as interneurons as well as other cell types which couldn't be studied without the presence of resolution. And also at the level of progenitors, there was no awareness of whether they are born from direct or indirect neurogenesis. So we made use of TBR to CRE-ER instead of FLIP. And what ER does is gives us a temporal handle where we can induce CRE at different time points. We used TBR to CRE-ER and crossed it to a CRE-dependent RFP reporter. We checked plugs, induced tamoxifen at specific time points starting from E12 all the way to E18, and analyzed postnatally. And we found that while layer 6 was produced at E12, layer 5 was produced at E13.5, which is expected, we saw several exceptions to the inside-out one-by-one layer organization rule, such that we found layer 4 and 6 being produced at E14.0, 3, 5A, and 6 being produced at E14.5. We also saw the same layer, for example, layer 4 being produced at 2 non-contiguous time points. And we also saw layer 3 being produced at E14 and then at E16.5. Later on, layers 3 and 2 were produced as expected. But look how there is a cohort of layer 5A neurons also being generated at the same time as layer 2, almost showing an outside-in neurogenesis. And this is almost 10% of the neurons that are produced here. We confirmed this with BRDU that there was the same pattern. So why should neurons, the same layer, be produced at two different time points? Is it a question of cell types? And so we set out to understanding projection types based on integrating birth stating as well as projection mapping through indirectly born neurons. We use the IS reporter or the intersection reporter I talked about earlier. We use TBR to create ER, and we induce it tamoxifen at certain time points. Neurons that will be RFP positive will be after it removes the stop cassette. And then we injected retrograde AEV flip into the target region of the cortex. And those cells would then turn green by removing the RFP cassette and allowing GFP. So what you'll see in the next slide is that there will be GFP positive cells, which is indicative of intermediate progenitors, the birth state as well as the projection target. The RFP cells that are like the Cree-dependent reporter with progenitor and birth state. And we injected fluorogold just as a projection target resolver with no genetic restriction. And so the two layer 3 neurons that you see here are produced at E14 versus E16. We wanted to look at it based on their projection targets. So we injected into the contralateral cortex as well as the striatum because those are the targets of layer 3 cortical neurons. When we injected into contralateral S1, we found that layer 3 that projects to the callosal neurons are present both at E14.5 as well as E16.5. Whereas when we inject into the striatum, we find that although at the later stage, layer 3 neurons that are born at E16.5 project to the striatum, the earlier born neurons do not, showing that there is a distinct neuron type that is generated within layer 3 at E14.5 versus E16.5, shown here in the quantification. So what we found in this is that although we see there is a deployment of projection neuron types and which largely follows an inside-out order.
Anjay, 20 minutes is up, so you have another 5 minutes to wind up. Thanks.
Okay. I will quickly summarize what I showed. Thank you for the time. What I wanted to say is it is in terms of the projection types, and you can see how 4 and 6 form part of the same microcircuit, and 2 and 5A also form part of the same microcircuit. And so specification may contribute to sequential assembly of cortical circuit modules. What I want to do in the future is to look at not just direct and indirect, but also competing models of radial glial organization that are based on transcription factor gradients from these cortical master regulators and which have different types of gradients in the cortex and can form, using the IS intersection subtraction reporter, give us an analogy of how different transcription factor types within the same radial glia can give us either fate-restricted neurons or all neuronal types. This gives me an into studying this toggling back and forth between humans and mice. And so we can study different aspects of autism spectrum disorders that are correlated with either lissencephaly, which is smooth brain. As you can see, there's lack of gyra and sulci, and between agenesis of corpus callosum, which also has a mouse model. So toggling back and forth between this in terms of organoids and using CRISPR on them, as well as studying human brain fetal samples, can tell us lessons from mouse, whether they can be applied to human models of research or not. And with this, I would like to end my talk that I would like to address 3 fundamental questions in development. One is the role of intermediate progenitors in diversification of neurons. The other is the role of neurogenesis and their relationship with circuit assembly. And third is what is the fate potential and lineage organization of radial glia. And with this, I would like to thank NBRC for giving me this opportunity to A, join them, and B, be part of this symposium. Josh Wang's lab is where I did most of the work, and therefore a big thanks to him. And Jessie Levine is an MD PhD student. This work was done at Cold Spring Harbor and Duke, and my funding sources from Human Frontiers and the NARSAT grant and the shared resources. Thank you all for your attention, and happy to take questions.
Any question?
It was a nice talk. I might have missed it. Was it did you look at a particular region or was it across the cortex? Because in medial prefrontal cortex, layer 4, for example, layer 4 is not that well developed. I mean, it's not well developed. I mean, like, it's not as distinguished as it is in other layers. I mean, other regions. So I was wondering if you see it across the other regions.
Yeah, thank you for the question. I think that's a great point. We did look at other regions. So the most of our analysis was done in the S1 barrel field because all the layers are very well defined. But this holds true for the medial prefrontal cortex, for the primary and the higher order motor cortex, as well as the visual cortex. So I did the same quantifications and analysis for different parts of the cortex. The injection data that I showed was done for motor as well as somatosensory. And so it holds true across different regions. The percentage may be slightly different within 5% range, but it still shows the same results.
Thank you.
Yeah, nice talk. There is a lot of work now in older animals and looking at the functional diversity of layer 2-3 cells and subpopulations within there. And I wonder whether you had, if the markers that you could identify in your populations and if they match onto any of these functional different cells that are seen later.
Yeah, that's a great question. We did look at a few markers and they do map onto a few of them. But what we are trying to do is to do a sequencing analysis using in the adult as well as the embryonic brains. And that will give us a much better idea as to whether it maps onto broad projection populations within layer 2 and 3. And so that's a very valid question and something we are very interested in addressing too.
Okay. Any further question? If there's no further question, let's thank Dhananjay one more time.
Thank you.
Our next speaker is Sharbani Shamadar. It's a short talk, 10 minutes plus 5 minutes discussion.
Am I audible now? Yeah. Hi, I'm Sarbani. I work in Saurav's lab here at NVRC. And today in this short talk, I'm going to talk about why synaptic translation is pretty important in ASD and how non-coding RNA, RNA binding protein interaction can regulate this synaptic translation. Like in Peter's talk before, around a fair few years ago, there was a landmark paper review from Mark Beer where he posited that aberrant synaptic protein synthesis is one of the major underpinnings for causing connectivity issues and functional network output in most AST-related syndromes such as Fragile X, PXC, Rett syndrome, etc. So this got me interested in trying to understand how synaptic translation really is regulated in the dendritic compartments within neurons, and mostly what are the regulatory components that decide the synaptic translation in like various aspects of the synaptic translation. Now there could be multiple regulatory RNAs, multiple regulatory elements for regulating synaptic translation, and this includes non-coding RNAs like microRNAs and long non-coding RNAs. So I was interested to understand how long non-coding RNAs can regulate synaptic translation in neurotypical situations. In order to do that, and all of you must have seen this in Saurav's talk yesterday, We prepared synaptoneurosomal samples from where we did transcriptomic analysis to identify synapse-enriched long non-coding RNAs. We also have a population of cell body enriched long non-coding RNAs that are mostly synapse depleted. The LNC RNA, the synapse-enriched LNC RNA that I'm going to talk about today is this one, which is HB, it's known as H16-RIC. We have named it as SYNLAM. Why exactly, you will come to know in the following slides. I also would like to mention that amongst the overall transcriptomic analysis that we did, of including the synapse and soma-enriched LNC RNAs, we had approximately 45%, which is not yet annotated, and the rest include various antisense bidirectional intergenic LNC RNAs. So one of these uncharacterized, non-annotated LNC RNA, which is synapse enriched, is this H16-RIC, which we've named the SYNLAM. This was an ISH done mostly to confirm the synaptic localization of all these LNC RNAs. This is just a fraction of what we have done, and this is a representative image. Here, synapsin is marked in green, and this is the ISH probes are marked in purple here. And the other aspect that we did was we did a lot of genetic analysis to identify that all the cytoplasmically enriched LNC RNA transcripts that we found were indeed synaptically localized because these did not contain any small nucleolar RNA within their sequences, which means that all of these genes have multiple transcripts. You know, LNC RNAs, like other mRNA counterparts, would have multiple transcripts. The transcripts that we identified at the synapse did not host any small nucleolar RNAs, which says that, okay, they are synaptically present and localized. So this is an example. This is SYNLAMP, and I have taken another synaptically enriched LNC RNA called GetPass. And moving on, what we wanted to study now is how these synaptically enriched LNC RNAs behave in response to neuronal activity. Now, in order to do that, we chose fear conditioning. The reason we chose contextual fear conditioning is because it is a very powerful stimulus and it is a one-trial learning method. Consequently, it is equivalent to adding glutamate stimulation in cultured neurons, because if we are looking at the hippocampus, then fear conditioning will allow a massive amount of neuronal activity. So we did fear conditioning, and then we made synaptoneurosomes from the dorsal hippocampus, which are mostly enriched in CA1 and CA2 neurons. And then we did qRT-PCR analysis. Interestingly, the time period we chose to do the contextual fear conditioning, the time period between training and testing was kept at 3 hours, because there has been a lot of work from Eric Klein and colleagues which show that post-training, that is post the learning incident, protein synthesis is triggered at the onset of 3 hours. So we wanted to study what happens to these LNC RNAs at the onset of translation initiation post this learning paradigm. And what we see is that several of these LNC RNAs, including SYN1, NO1, including SYN1, SNHGs, PVT, PANTA, these are, there is an increased abundance of their presence in the synaptic compartment, which means somehow they are getting transported towards the synapse from the dendrites post this post neuronal stimulation in the form of fear conditioning. Now, if that be true, then do they play a role in dendritic translation at all? In order to understand that, we did a puromycin labeling experiment along with non-canonical tagging, where we found that, okay, each of these cultured neurons, we knocked several of these LNC RNAs out. In this representation, I'll be talking about PVT, PANTAR, and SYNLAMP, 3 synaptically enriched LNC RNAs which were knocked out. And in the knockout condition, we treated these cells with glutamate in the presence of actinomycin D, actinomycin D being a transcriptional inhibitor, because we did not want any sort of spurious transcription to come into the picture while we were looking at novel protein synthesis upon glutamate stimulation in the background of these LNC RNAs being knocked down. So we scored these protein synthesis through the incorporation of puromycin. And this graph shows the mean signal intensity of the puromycin, which is a direct sort of readout of newly synthesized protein in this situation. And we find that if you look at this particular set, that when we have knocked down SYNLAMP, in spite of there being massive glutamate in the system, there is an abrogation of protein translation. So we decided that, okay, SYNLAMP does play a role in protein translation. because its absence is causing protein translation to be absent. So this was our final idea, from whereupon we went on to the further experiment. The further experiment was to know how do these LNCRNAs regulate protein synthesis? What are their binding partners? In order to do that, we went back to metadata and found out all the RNA binding interactors of these synaptically enriched LNCRNAs. These lines, the strength or the width of these lines show the strength of the score of their binding interaction. And from them, we have tested several of these RBPs. I'll be talking about FUS, which binds to many of these LNCRNAs. So we immunoprecipitated FUS from the dorsal hippocampus upon fear conditioning, and we found out that FUS, this Western blot shows that FUS is immunoprecipitated, and we checked the association of these LNCRNAs, which were reported here, and we wanted to check whether indeed FUS associates with them in actuality. And we found out that there is an increased association of SYNLAMP with FUS upon contextual fear conditioning, but Panther and Rick are really not changed. There are several other LNCRNAs which showed no change in the association between FUS and the LNCRNA. Next, we thought, okay, we were looking at overall dendritic translation before. What is exactly happening at the synapse? So in order to do that, we designed something called SERTs, which is a CRISPR-based method to localize guide RNAs against SYNLAMP to the synapse upon synaptic stimulation. And this was done by Bala, and this SERT control was made in collaboration with Tim Reddy's lab. And we found out that, okay, upon knockdown of this SYNLAMP in the presence of SERTs, like we use SERTs to knock down SYNLAMP in cultured neuron cells, upon activity, we see that there is a change in the miniature EPSC amplitude, which you know is a postsynaptic effect, but no change in the miniature EPSC frequency, which shows that SYNLAMP is acting in the postsynaptic compartment, and somehow its association with FUS is regulating its output, the postsynaptic output. Now, there was this question, this graph you saw earlier, we see that during glutamate stimulation, there is an increased amount of SYNLAMP present in synaptoneurogens. However, there is no change in the amount of FUS that is transported to the synapses upon stimulation. FUS remains unchanged, and this was done in from the hippocampus of animals who were subjected to contextual fear conditioning. So these are the endogenous FUS levels in the synapses post contextual fear conditioning, and these are the endogenous SYNLAMP expression levels in the same synaptoneurosomal compartment. So we thought, okay, so something is happening which is allowing these SYNLAMP transcripts to be preferentially go move towards the synapses, where it is binding to the available FUS, because FUS is not getting co-transported along with it. It is binding to the available FUS, and maybe our working model was, if it is binding to FUS, where FUS is a known translational repressor, much like FMRP, maybe it is asking or allowing FUS to get removed from its cognate mRNA targets, which allows FUS repressed targets, hitherto repressed targets, to be translated upon synaptic stimulation. This was our working model. If that be true, then whatever protein synthesis that should happen in this synapse upon stimulation should also have FUS targets in reality. So what we did was, we did a PURO-PLA experiment. Quickly, I'll go through it, where we looked at the identity of these new proteins that were synthesized in the neurons, and we found out indeed that one of them we chose was CAMK2, and we decided to look whether CAMK2 was a newly synthesized protein upon the same puromycin labeling experiment, and we found out that when SYNLAMP SERTs is used and SYNLAMP is not there at the synapses, then CAMK2 is not translated even upon activity, which proves our previous hypothesis here. So we also did certain SYNLAMP knockdown studies to see how this is translated to behavior, and we saw that SYNLAMP knockdown does inhibit fear memory. So in conclusion, to summarize, this is our working model. We think that in response to activity, LNCRNAs like SYNLAMP move to the synaptic compartment and acts as a decoy for RBPs, which may cause protein translation increase if the RBP in question is a translational repressor, which may cause other sorts of effects if the RBPs are translational activators. So to conclude, LNC RNAs could act as decoys. We are currently looking more into this and figuring out whether this is a proof of principle that can be extended to many more LNC RNAs. With that, I would like to thank my PI, Dr. Saurabh Banerjee, Bala, who did the path clamp experiments, Nandu, and Jongi, who did most of the bioinformatics, and all my lab mates, and also to DBT for funding this project. Thank you so much, and I'd like to have questions.
Questions? Okay. Student, anybody wants to ask question? Okay, I think.
So for your decoy idea, have you looked at the sequence elements in your link RNA in terms of motif densities and comparing different link RNAs and their different motifs? And because there are two possibilities. One is that it's really in the sequence of a link RNA what you can absorb or tether, or the other would be that the sequence of the link RNA itself is not that important. It's only important that it's transported and positioned in the right place in the right time. So it may have a sequence module, but purely for its spatial temporal control, not for what it might be absorbing.
Right. So we have not done that yet, but there is an interesting approach to do this really. If we can look at the motifs for FUS, which we are currently looking at for all these LNC RNAs, and that is how we got the data from PostStar, where these motifs were present in these LNC RNAs and which bound to these RNA binding proteins such as FUS and PDP43 and all this. The other interesting thing that we can look at in reality is whether these are also binding to some proteins which are helping it to get transported to the synapse. And there it is now relinquishing those proteins which are getting which are helping it to get transported to the synapse and then bind with FUS to see these changes. So maybe the motives for which we should look at is both the RNA binding proteins at the synapse and also some things which are helping it to get transported to the synapse. We have not done this, we should.
Okay. If there are no further questions, let's thank Sharbani one more time. And let's move on to the next and the final talk of this session from Dipanjan Rai from IIT Jodhpur. Dipanjan, can you hear me? Dipanjan? And also there is tea and coffee outside. If you'd like to have some, you can go out and bring tea, coffee inside, right? And you can call him also. It's there. Okay, Dipanjan, can you hear me?
Yes, I can hear you.
Yeah, can you share your slide?
Yes, I'll do that. Just let me know. I have just shared.
Yeah, no, full screen.
Is it visible?
It's visible, full screen now.
Yeah.
Perfect.
Is it fine?
Yeah, you can start.
Okay. Just wanted to know like how much time I have.
Followed by question answer for 5 to 10 minutes.
20 minutes plus 5 or what is it?
Yeah, so 20 minutes, you can consider 20 minutes plus 5 and then 5 minutes for questions.
Okay, okay,
so total 30.
Perfect. Yeah. So thank you, everyone. I'm really sorry, first up, that I cannot be with you in NVRC, which is a shame. But unfortunately, there is another conference which is going on at the same time, and I am also speaking over there. So we have to manage this. So what I'm going to talk about will be a gear shift for you, and I hope you can hear me clearly. And in this work, actually, which is like very fresh work from the lab, where we are trying to understand essentially specific brain patterns and fingerprints, which is collected from children's in the age group of 3 to 12 years, and specifically in the context of atypical brain development, to find out the signatures or neural signatures that actually tells you about their brain dynamics, connectivity, and also neural flexibility, specifically in social cognition. And the way it goes is that we are very interested in understanding social cognition, particularly in the context of mentalization of our internal states, and as well as the ability of the children to understand others and others' beliefs, and very aspect of what is known as theory of mind. So in the first part, I will give you some examples of that. And as we move along, I will take you through some of the analyses that we have actually looked at in order to understand whether some of the deficits that you find in autism spectrum disorder, whether they come from certain kind of global signatures of atypicality in the core and peripheral brain regions during spontaneous activity in the brain and recorded through resting state functional connectivity, and also to quantify with development of new methods in order to track neural flexibility of these core and peripheral brain regions and modules, which leads to, in our understanding, largely responsible for the sensory and the socio-cognitive deficits that you observe. And if time permits, I will also touch upon what happens when the children's watches movie clips and other kind of naturalistic stimulus and carry out some of these tasks, which is related to the theory of mind and mentalization task, and how do their behavioral performance changes, and whether we could use these kind of neural flexibility and other dynamical changes or dynamical patterns as predictors for those task performance. And there will be some remarks in the conclusion. So when we talk about social cognition and theory of mind, just to put it simply, it's a complicated topic, but just to put it simply in a psychologist's language, is the ability to put yourself in others' shoes, or something which you can call mind reading, or understanding others' humors, sarcasm, etc., etc. There are two particular aspects which I would like to point on from the very beginning or from the start, because this is the kind of stimulus that I'm going to also show you at the later part of the talk, which relates to understanding hunger, pain, which is related to processing of the pain or sensory processing in the bodies, which is something like internal. On the other hand, something related to higher order cognitions like mental states and understanding other people's mental states like beliefs, desires, emotions of others' minds. One question that comes for example, I am leaving you, and therefore when you make a statement like I am leaving you, naturally the question comes is, who is he? Whether the children's brain actually develops at a particular age is sometimes indicated by the words they use and the way they behave and the way they learn those concepts. So therefore, when you are studying this kind of, or interested in this kind of social cognition and their impairment or atypical development, there are three groups that are particularly crucial to understand. One, the people who has a hidden world, like the autistic, individuals. Then comes the children, because their ability or mentalization ability is a key aspect in the way they perceive others' pains and body states, and also mentalization of the concepts. And the third, obviously, scenario, which was very elegantly put by Primack and Woodruff way back in the 70s, where they coined this term as theory of mind, which has been used also to frame the question whether the primates have very similar kind of, changes in the theory of mind ability as human individuals or human subjects. And 30 years later down the line, like when we look at like literature, there's a question that haunts us, is that whether the chimpanzees or non-human primates have a theory of mind themselves when competing with others for food, for example, whether they can recognize the competitor, whether they can or cannot see or hear even what the competitor does or does not know. And some of these actually constitutes what is known as false beliefs. That is, the performance did not improve despite knowing competitor sort of held a false belief. You can see these ability also in the children, in the typical infants, and their ability to understand and interpret and respond to other thoughts and behavior. And some of these data were collected in Boston Children's Hospitals, where people have given tasks to the children's in order to understand their social cognitions and their ability to develop this theory of mind. So in principle, these can be categorized as their ability to use perceptual words such as see or look, words for physiological states such as hungry, tired, which I already mentioned, emotional words such as scared or happy, and desired terms such as want, etc., etc., and mind-related words like belief and think. So if we continue on these, we first of all want to operationalize these for understanding the mental states. It is crucial to understand how brain areas or their neural correlates are, right? And to be able to relate that or correlate that to the behavioral variables that we collect in the laboratory conditions or based on our stimulus. So the functional brain networks that are responsible for recognizing other mental states, these are crucial for social cognition on the first hand. That is what we hypothesize. The second thing we hypothesize that there is four stages of development through which these functional brain networks and the modules actually undergo significant alterations and reorganizations. So the first 2 years of life is like more sensory motor, so where these abilities of sensory motor processing, sensory motor reorganization changes. And interestingly, with aging also, there are existing evidences in our work as well, which showed that the sensory motor reorganization and stability is very critical actually for the overall understanding of the brain development and aging. And the second few phases from 2 years onwards, all the way to 12 years, is the interpretation of the child to use symbols like words and images to represent objects, but does not reason logically. So many of the children at that particular age, when you give them tasks which related to mentalization of the concepts, they actually fail rather than pass in those tasks. And I will show you some data from the behavioral experiments as well. Okay, but the adolescents can reason and abstractly and think in hypothetical terms, and their fingerprints of these reasoning ability of thinking abstractly in hypothetical terms can be correlated with the neurodevelopmental changes, specifically by looking at the brain networks organizations. And autism spectrum disorder is a very interesting, obviously, pervasive neurodevelopmental disorders that impairs the ability of the participants in their social cognition domain, in also communication, as well as their interaction abilities, compounded with the repetitive and restrictive behaviors. So therefore, the first question that we try to understand in our analysis is how atypical development leads to like a global reorganization in the core and the peripheral modules or brain regions in resting state functional connectivity. Obviously, all of you are aware of that autism leads to auto or locked within themselves, removed from social interactions. That is the term that actually gives rise to these deficits in impaired social communication and rigid and repetitive patterns of behavior and interest. It has a lot of implications for the theory of mind, as I have already said. But the most interesting aspect is to look at like how the executive networks of the brain or decision-making networks of the brain actually relates to the sensory motor network, which I have already told in my previous slide. And the very interesting hypothesis is to check actually if there is some kind of an inhibitory control over there, which leads to this repetitive restrictive behavior, and whether there is also aberration in terms of the core and peripheral modules organization in the default mode and salience network that is actually inefficient in processing information from outside. And the default mode and the central executive network, their change in the connectivity may be importantly associated with the social communication deficits. So what we look at, we first of all conceptually look at the hub shifts, which is localized in primary sensory and motor cortices. And we look at essentially children in the age group of 5 to 10. That is basically has been shown in the existing literature where there is a shift of hubs from primary to association areas, which mirrors the development of higher cognition or higher order cognition during this period. So the open ends on the literature when we started this work was altered modular configuration, which has people not been looked at in the literature. So we looked at the altered modular configuration. How does it arise from the atypicality of the node that is affiliated to a given module, such as, the nodes that were supposed to be part of the sensory motor modules, how they are connected with the other modules in the sensory motor network, or whether they are showing some interhemispheric connectivity with other modules and other networks of the brain, which will lead to some kind of atypical functional connectivity and organization. And we want to find out also the contribution of the nodes properties to these atypical module configuration of the neurocognitive networks, and particularly study their correlation with the ASD behavioral traits. So with that, we actually looked at these concepts very quickly. I'm kind of running through it. Some of these data actually were recorded by Abide cohort, where they looked at the early school children in USA in multiple centers with similar scanning protocols to reduce heterogeneity. And in 5-10 years, and most of them had an IQ of greater than 75, the answer we provided in the literature is to look at the modular composition of different modules, then the modular connectivity, and finally the functional cartography, which apparently correlated with the ADOS scores as well as their symptom severity patterns in social cognition domain. And the way we have calculated these is we actually looked at the, different clustering techniques in which actually the brain networks can be, or the nodes can be clustered together to identify their modular composition and connectivity patterns. So if certain nodes have actually high between module connectivity, but lower within module connectivity, it would suggest that there is an increase in the global integration at the expense of segregation of the networks and specialization. And we wanted to understand how much these segregation and integration in the reorganized modular organization in atypical development actually affects the people. To test the robustness of this finding, we have actually varied the parcellations, because the parcellations can actually lead to differential results. We tested these with coarse to smoother parcellations of the cortex and found out the results to be true in all the cases. And the community structure of individual subjects were assigned using what is known as normalized mutual informations, where in your matrix, you can have entries along the rows and the columns, which actually give you the mutual information scores of the participants in order to track whether the mutual information, or like the normalized mutual information, which is restricted between certain number like 0 and 1, where does these lies in typical developing children versus atypical conditions? And what you find based on these, that the community structure is becoming completely reorganized, and there are differences in specific modules like sensory motor, dorsal attention, central executive, and also default mode networks, which has been hypothesized for higher order cognition in typical developing children. And these group level differences also shows up when we do within module degree analysis and estimate the intermodular connectivity as well as between module connectivity between these set of brain areas which are located in precuneus, then lateral orbitofrontal cortex, also involving limbic regions which are very important for reward processings, and as well as dorsal attention networks. We also find that the connectivity between networks actually significantly negatively correlates with the cohesiveness of the modules. That means the modules are becoming actually less modular, and they start actually kind of correlating their activity with other brain modules, and in that process the cohesiveness of the module or the functional specialization actually decreases. On the other hand, the participation coefficient, which is a measure of the degree of interconnectivity between different modules, actually increases with age, and as well as shows the difference between typical developing group versus autistics. So we put it in an aerial map in order to show actually that there is a sort of increase between network connectivity in autistic individuals, which were highly statistically significant after FDR and family-wise error rate corrections. And there is an increased connectivity between the default mode networks, which is related to the self-related processing in individuals, along with central executive networks, as well as between sensory motor and salience network, that actually explains the hypersynchronization that you observe in the autistic individuals in comparison to the typical developing group. So the interim summary is that the functional hyperconnectivity and increase in between module connectivity and reduced alteration in node community membership in DMN, sensory motor and saliency network, that altered modular configuration arise from atypicality of a node affiliated to a given module. There is contribution of node properties which leads to hypoconnectivity and decrease between module connectivity, and increase alteration in node community membership in dorsal attention and central executive network, and this dissimilarity in modular composition which drives actually some of the atypicality. Saurabh, do I have 5 minutes? Saurabh, 5 minutes is okay?
Yeah, 5 minutes is okay, yeah.
Fine. So the next question we asked is that the development is not static, right? It is extremely dynamic process, and it can happen in multiple scales, as we are observing from the other talks as well, where you can look at it at the synaptic scale, you can look at it based on the interaction between brain regions, and you can look at these at the developmental time scales as well. So we actually tried to understand, if we look at the dynamicism of the networks or dynamic networks, how they are relevant to the social cognition process. Because these dynamic networks has been shown in neuroscience is important for learning, as well as when people age, or to track like progression of disease or memory, learning, and attention all together. So therefore, we looked at the switching of the brain states as the brain states go through different state transition probabilities, and they spend some significant amount of time in one type of connectivity versus another type of connectivity for significant period of time. For this, we have used actually data from New York University, and where we have actually looked at children, adolescent, and adults to look at the developmental differences, and also like look at the interaction between development and age by diagnosis. The way you can construct networks is you can look at either the sequential graphs by looking at like task wise how these networks and the nodes and their connectivity gets reorganized. Therefore, you get in each layer a single functional connectivity matrix, and you can choose a windowing scheme and create pairwise functional connectivity matrices over each time window of recording, and align matrices in time and couple each node to itself in the following matrix to derive their variability as well as their mean connectivity patterns. You can also use in those multiple layers a modularity to estimate the community structure, much like the way in the first part of the talk I described about modularity, but except now you are calculating this modularity in multiple layers. What happens in the end process is that you have a number of times a region changes its module allegiance, normalized by possible number of changes over time. And the community assignment becomes a dynamic process which you can study, which is very relevant for autistic individuals in comparison to neurotypical, specifically for social cognition task, right? So we look at the fraction of regions that actually participates in the process and identify actually the same set of brain areas which are located in the core and peripheral nodes. They show some variability of this dynamic functional connectivity in the children in the age group of 5 to 10 years. And these quantifies their atypical flexibility. And we find out there are both long-range connections, functional correlations, medium range correlations, as well as short-range correlations. And it has a directionality that the hyperconnectivities, there are few hyperconnectivities which give rise to the global pattern. We also see there is a change in the regional flexibility as you go from children to adolescents to adults. So there is a developmental variable which actually affects their functional connectivity and regional flexibility. And finally, the modularity and the flexibility among these two measures, the functional specialization is negatively correlated, obviously, in ASD, but they are more relevant for neurotypicals. That means basically the flexibility predicts the symptom severity in social cognition domain in autism rather than the functional specialization. So I will also show these slides almost at the end of my talk is that what is going on to depict that particularly, we look at the primary sensory areas, which are peripheral nodes, to DMN or default mode networks, which are like core areas. And what we find by doing a gradient analysis or a functional gradient analysis, that there is a suppressed gradients. That means the information from the stimulus is coming to the autistic individuals, but the functional connectivity and the propagation of the information flow or the information routing from the sensory areas is somewhere halted. It is not reached up to the core areas of the brain, which is one of the bottlenecks why there is a information loss, which is leading to the atypical behavior. So just the last part of the talk where we use actually children's in the age group of 3 to 12 years, we show them movie clips, which are animation movies. And when I say we, this data was recorded in Boston Children's Hospital and at MIT. It was collected from 122 children and 33 adults. They perform a task, which is a theory of mind task or false belief task outside the scanner. And inside the scanners, as you see, there are labeling of the TOM scenes and the pain scenes. So there were high activations in the fMRI from specific set of brain regions, which are known as the social cognition nodes of the brain. Okay, and with these data, we actually developed a technique called, dynamic functional connectivity subspace estimations. From the dynamic functional connectivity methods that I showed you in the previous slide, where you can do layer-wise analysis or like sliding window-based analysis. And based on that, you can do a quantitative characterization of the stability of these networks during the early development to understand the internal states of other bodies versus internal mental states. And what we found that in those scenes, for example, which are related to pain and Tom clips, for example, the children's given their response. And if you look at the data on the x-axis, the 3 years old to 13 years old, there is a transition point, right? Where the children's proportion of correct response during Tom task is actually like, developing. Their understanding and mentalization and reasoning ability is improving, and therefore they are passing those tasks. Whereas the children who are generally like, 3 years, they are not able to like respond to those stimulus correctly. And there are also few inconsistent responders among those 122 children. Moreover, the specific scene or the clip of the movie actually activates the theory of mind regions of interest that I showed you in the previous slides, and their activity actually correlates very well with the behavioral response of the participants. So based on this idea, we analyze their DFC subspaces or dynamic functional connectivity subspaces, and we already see for those movie clips and their temporal segments, while they are parsing that scene or watching that scene or experiencing that pain-like scene in the movie clips or Tom-like clips in the movie scene, there is a differential functional connectivity between those children's of the age, those age groups, which matches with the behavioral responses. And we find that the association between performance of false belief tasks in children and the temporal stability of this dynamic functional connectivity landscape or subspace, they completely able to predict people's action, beliefs, desires, and moral blameworthiness, right? Which is like, you have to take it with a grain of salt because it's a selected sample on which we are kind of trying to understand Tom networks and children's ability to kind of develop this theory of mind ability based on some dynamical analysis. But the summary of all these things can be presented in 2 lines. One is aging actually introduces temporal variability in the evolution of dynamic functional connectivity or correlation between brain regions, and the Tom and pain functional brain networks segregates very early during like, processing sensory versus like internal state representations. And that segregation actually can be very useful in understanding how specifically this ability develops in the children during development and their aberration or atypicality in autism spectrum disorders as well. And the last point that is very interesting is that the temporal stability of the dynamic functional connectivity and of these Tom and pain brain regions or functional brain networks during movie watching, which is a very naturalistic task, is actually predictive of performance of children in 3 to 12 years during typical development of processing others' bodies, like those cartoon clips, bodies like hunger, pain, versus internal mental states like belief, desires, and emotions of others' minds. So thank you very much for your attention. I would like to thank the entire lab, which partly was in NBRC when I was a faculty over there, and my collaborators include Saurav Banerjee, Aninda Ghosh Roy, Arpan Banerjee, and as well as people from outside India. So thanks very much.
Any question?
Saurav, if there is any question, you can relay it to me, right?
Yeah, it was a nice talk. So I have 3 questions.
Yes, please, please.
So the first one is, from my understanding, you were looking at the emotional aspect of the kids, right? So
Sort of, right. I mean, not exactly like emotions, but it has a lot of overlap with the emotion processing, because the same set of brain area like temporoparietal junctions or salience networks, they have a very important role to play also in emotion perception, emotion recognition, etc., etc. Yes, so you are right. Yeah.
So in that case, did you come across any situations where when you consider a neurodiverse kid, did you see any compensation for emotional processing with logical or pattern recognition area or something like that when compared to a neurotypical population in an average?
Right. We have not looked at that aspect over here because the stimulus that I showed you related to the movie clips, they actually have those kind of scenes which are related to Tom and pain regions activations, right? Stimulus induced activations, which you see in the fMRI peak signals or bold signal changes. But having said that, there are also possibilities of understanding what is happening in the change in underlying anatomical networks, because this was mostly functional, right? Okay, so in functional, either you are looking at the correlations or time dependent correlations in the way we were actually trying to understand the altered modular configurations as well as the temporal changes. But if there is some kind of structural changes, right, anatomical changes in the white matter fibers or gray matter volume or fiber densities, then you can ask the same questions that what actually is compensatory over here in terms of like functional compensation, right? How do they compensate for the change in the underlying anatomical connections or anatomical differences? Okay, and is there any kind of signature over here that can actually tells you how these brain regions are responding to the task or the stimulus, and whether some of these can be thought about not like an altered changes, but rather the changes that is actually compensating for something, right? But what is it compensating for? Actually, that is not very clear, right, over here. So therefore, what you are finding is basically an early segregation between the pain processing areas of the brain and the theory of mind processing areas of the brain, which attributes, belief, and desires, and all the other like qualities and attributes of others, right? Yeah. So you can differentiate up to that much, but to differentiate like whether those changes, some of them are compensatory changes, is probably a little bit harder to talk about from these data. Okay. Yeah. I mean, if you understand, right, what I'm saying.
Yeah, and I have
Yeah.
one more. Like the clips that you had shown for the kids for triggering an emotional response, did
Right.
that
Right.
include like was it something that would work for a population in general, or did it have anything, for example, for a kid in the spectrum? I would, I mean, from what I have read, the emotion would be different. I mean, if you're going to show an ET movie, a movie
Right. Right.
trigger
Right.
a different emotion when compared to, you show something that a neurotypical person would, it would elicit the same response from you. Did you try different ways of emotions as what?
We have not, because you saw the data which composed of 33 adults and 122 children in 3 to 12 years. And these children are all neurotypical, right? Okay. So the very interesting extension of that would be what you are also talking about or suggesting is to kind of use these sort of movie clips, okay, in people who are found out already by other analysis that I showed in the part one of my talk, which has altered, let's say, modular configurations in the same set of brain regions, like autistic individuals, age matched, maybe gender matched also, and then look at their developmental differences based on how they process those scenes, right? Yeah, and how the emotional areas of the brain, like amygdala or like orbitofrontal cortex or medial and lateral orbitofrontal cortex, ACC, anterior cingulate cortex. How do they process actually these informations in those individuals? And if there is a altered regional flexibility, right? Okay, or neural flexibility, which can be very important, like sort of biomarker, you can say, right? Between understanding like how typical developing individuals are processing those scenes versus those who are in that atypical developmental phases, right? Yeah.
Yeah.
But we have not done that. So we have no clue, I mean, how these will pan out. And in general, this is a task, you understand, which was done, the movie watching task inside the scanner. It is very difficult to control for motion and movements, right? We have to really like go through a very rigorous procedure during the pre-processing of the data to remove all the kind of, motion which were like censored for the frames that were collected, because the children's obviously moves a lot inside the scanner, so there are very high degree of difficulty to collect these kind of data also in the autistic individuals. But that said, like some people are also putting those efforts, so maybe at some point of time we'll have data to talk about that more clearly. Yeah.
Okay, thank you, Dipanjan, and for excellent talk. And if there is no further question, let's thank Dipanjan again. Yeah.
Thank you. Thank you. I'll stop sharing. Yeah.
Yeah. Yeah. So with this talk, we come to an end to this 21st NBRC Foundation Day Symposium. And before I conclude, I really need to thank a lot of people who worked behind the scene and made this symposium possible and enjoyable for all of us. First is our canteen staff and our master chef, his name is Bishnu Pada Sahu. We fondly call him Bishnu. So all the food that you have taken last 3 days, he prepared it, and he went to the market and from the scratch he prepared it. He right here. This is the first time we were able to do this, so that we can have a healthy food. And he was supported by a supporting cook, and there are a few people in the canteen, Sanjay, Ravinder, and it is coordinated by Sunita, who was immensely helpful for coordinating all of this logistic arrangement related to the refreshment. Our admin staff, all of our admin staff, particularly Irshad, was really helpful for coordinating all the movement. People are coming from the airport, bus services, everything. All of our finance staff, particularly Sanjay Singh, who is helping us to collect all the forms. And a lot of people work behind the scene from the engineering section that made this venue really well and then clean all the time. And particularly Mahinder, whose help was really helpful, and to coordinate with all the stuff. Then the DIC, its computing facility, and they worked tirelessly to arrange all the talks and communicate with the virtual speakers and with all of us setting up the talk. Kedar and Tarnum, and academic office, and all of the academic office staff, including Shivani Tanwar, who is our academic officer. She is one of the main coordinator. Without her help, this particular symposium wasn't possible. And all of our purchase section and all other admin staff. So big hand for them, actually. Then this meeting was organized and it went through seamlessly for many volunteers who participated in this particular symposium. And I will tell name one by one: Bala, Sharbani, Kamakshi, Dipanjana, Sania, Pallavi, Shreyas, Reena, Ningchangmi, Gauri, Dhey, Chaksu, Sukriti, Arya, Ashish, and Bibha. Big hand for them. So they really worked very well and very well coordinated manner, actually. And then, of course, my co-organizer Aninder Ghoshrai and Shefali. So we had a very nice discussion how to arrange this particular symposium, what topics to include. It was a lot of work that went almost for a month or so, more than a month actually. And our former director, Professor Krishanu Ray, who is here with us, and our current director, Sagar Sengupta, who will be here with us tomorrow with all this actual Foundation Day 16th December celebrations. And we actually invite school children for an open house. And I would like to thank both of them, Krishanu and Sagar, for their continuous support for all the scientific activities and making this symposium possible. And thank you all for coming in this weekend, like Saturday and Sunday. It was particularly arranged on Saturday and Sunday so the clinicians can come, because they are very, very busy in OPDs and their patients in the hospitals. Thank you all. Thank you.